Very important. So let me get this fired back up. Get the record started. 30 that's 30 number 4.
Kobe asked me smoking Newport cigarettes, check off the bathroom somewhere. One of those.
Okay, recording is started and we're ready to cover a very important topic. Now, last time we started with trauma. We did trauma to the head. We talked about epidural and subdural. Now we're going to talk about cerebral vascular disease. This is a big killer. Remember, number one killer of American is an MI. Next killer is going to be cancer, specifically lung cancer. Then number 3 and number 4, they're kind of neck and neck, would be cerebral vascular disease, strokes, kind of tied with COPD. So it kind of switches. One year it'll be third, the other one will be fourth, and then they'll switch. So this is in the top 4 killers of an American. So very important to remember strokes. Now, strokes have the same risk factor as MI. The same risk factor, atherosclerosis, so hypertension, smoking, hyperlipidemia, cholesterol, inactivity, all those risk factors we talked about for coronary artery disease, well, they can affect the cerebral vasculature as well. So very similar risk factors. And it is the most prevalent neurologic disorder in terms of both morbidity. When you have a stroke, you're disabled, you can't work. And mortality, it's one of the top 4 killers. So very important to learn it and learn it well. And it's usually caused by one of 2 processes. Number 1, hypoxia of tissues because of ischemia, lack of blood flow. So basically that's going to lead to infarction because you're not perfusing the brain. Brain needs oxygen like crazy. And the other way you can get a stroke is to bleed in your brain, hemorrhage. So that usually requires a ruptured vessel and subsequent bleeding, high pressure, the brain gets squished, neutrophils and macrophages come in, they eat all this brain tissue, and you basically have brain damage because of the bleed. Now, which is more common? Well, ischemia and infarction is much more common than hemorrhage, but which is more lethal? Well, they both kill you. Infarcts kill you and hemorrhages kill you, they both kill you. But hemorrhages have high pressure, so the risk of herniation is really, really high. So hemorrhages are less common. We'll talk about them. They can be in the brain, or we talked about outside the brain, epidural, subdural. But they're also very likely to kill you. So less common, but very dangerous. So we'll do them both. Now, the brain is our critical organ, right? That's how we think, that's how we do everything we need to do. So we need to feed it all the time, glucose and oxygen, because the brain runs on aerobic glycolysis. So that's why your liver is constantly releasing glucose to maintain glucose level when you're not eating. So the liver's going to pour some sugar on the brain, so it always has something to eat. And of course, oxygenation. Remember, the brain has its own regulation. Brain is auto-regulation. It's that critical. So no matter what my systemic blood pressure is, the brain to a point can try to regulate it and can maintain blood flow to the brain. So if I get hypotensive, the arteries in the brain will open up to try to get some of that pressure to the brain. It's critical, one of our critical areas, got its own regulation. All right, now since the brain is highly aerobic, it's going to need that oxygen. And notice 50% of resting cardiac output goes to your brain. Now 20% of the total oxygen consumption of the body is consumed by the brain. So that's a hungry little sucker, especially now when you're thinking, when you're using your brain, it's going to need even more oxygen. Now, mechanisms of oxygen deprivation. In other words, how do you get cerebral hypoxia? Well, what if you're at high altitude? If you go up to the top of the Himalayas, you might need supplemental oxygen because you have very low partial pressure of inhaled oxygen. So very important to make sure you have a good oxygen in the air. So high altitude, you may have to give supplemental oxygen. What about the blood's oxygen carrying capacity? Well, either anemia, where you have less hemoglobin, less trucks or Uber cars to carry oxygen around, or do you remember hemoglobin has actually 4 sites for oxygen? It's got 4 sites for oxygen to sit. Well, what if carbon monoxide comes in there? and that hussy takes the seat. I'm taking over. Poor oxygen only has one seat when it's supposed to have four seats. Well, even though I've got the Uber drivers, I got the cars, they're not filled with many passengers, or at least the passengers are not paying. These are freeloaders. So unfortunately, I can have good blood, but it's not carrying oxygen because carrying carbon monoxide. So that would be an example of decreasing the ability of the blood to carry oxygen. So anemia, carbon monoxide. Now what about inhibition of the oxygen use in the tissue? What could stop the tissue from using oxygen? Oh yeah, cyanide. Cyanide. Remember a firefighter coming out of a house fire, and sure enough, he's holding his head, he's holding his abdomen, he's holding his heart, because he's getting ischemia of his organs. Because basically, the oxygen is getting to your brain, but the electron transport chain is blocked. Remember, the reason you need oxygen is to accept electrons, to make ATP. Well, if the electron transport is blocked, even though oxygen's getting there, it ain't gonna work. Your body can't use the oxygen, can't make ATP. So this normal cyanide, oof, not too much of it can kill you. Very, very dangerous substance. And then, of course, ischemia, lack of blood supply. Now, this is a biggie, right? Ischemic disease, atherosclerosis, emboli, herniation, where you're compressing the vessels. So ischemia, lack of blood supply, is a big one we have to talk about pathologically. Now, this blockage of blood flow could be transient, which could give you some mild deficits, which will return, or it could be permanent, where you're going to have permanent loss of neurologic function. Not a good thing. Now, some examples are vascular occlusion by like an embolus or a thrombosis over an atherosclerotic plaque. And of course, herniation. Herniation could be external compression of the vessels too. And then of course, decreased perfusion. If the pump fails, or you don't have enough blood, or you go into shock, whatever reason, if there's low perfusion pressure, the brain will try to autoregulate, but it can only do it to a certain extent. If it's severe, like for instance, somebody actually dies, their heart stops, and then a medical student rushes in and saves their lives, well, you get the blood returning to the brain, it's sometimes too late for some of the cells, and they could die. So very important when there's decreased perfusion. Well, do you remember the most sensitive area? The hippocampus, C1a, summer sector, and the cerebellum, the Purkinje neurons. And then one more thing that I ask about this, decreased perfusion, you should get infarcts in the, what you call watershed areas. The watershed. So if I go back to her picture, it's a while back a bit. Oh yeah, go back to this picture. Remember the anterior cerebral arteries are here, and they get blood to this area. And then the middle cerebrals are here, and they give blood to this area. So on the picture, if there's severe hypotension, you're going to see infarcts here and here, bilaterally, because the low perfusion is affecting both sides. So isn't that a very weird distribution? You got infarcts right in those two like areas, and that's in between the blood, right? So there's not enough blood getting to that area from here, not enough blood getting from there, and that's the problem. Those areas are getting infarct. So that's kind of an important thing to remember. Watershed areas and hypotension. Again, we will see it. We will see people get resuscitated and wind up with infarcts, unfortunately. All right, now let's talk about the different types here. Back. Here we go. The different types clinically of cerebral vascular disease. There are two forms. Number one, transient ischemic attack, TIA, and the key word here is the word transient. That's the key word. So it's an ischemic attack, but it goes away. So this is transient loss of neurologic function, but luckily it returns within 24 hours. Now in real life, it usually returns pretty quickly, within minutes. So like the face droops, and then like 10 minutes later, it comes back. So it's usually transient and usually within a quarter of minutes. It really depends on how long it takes for the clot to break up and get blood flow back to that area. So transient loss of neurologic function, then it returns within 24 hours. Now it often manifests as loss of vision. And loss of vision is very characteristic. It's like a curtain coming down. That's how they describe it, loss of vision. They call it fleeting vision, like a curtain coming down, amaurosis fugax. It's a classic sign of a TIA or potentially a stroke. If it doesn't come back, it's a stroke. Facial drooping is very common, arm and leg weakness, confusion, trouble speaking. That's a big one too. So these are the classic features of a TIA and stroke. Now, these return back to normal, it's a TIA. If they don't get any better, it becomes permanent, that is a stroke. So people often call these warning strokes or mini strokes because they're a harbinger. They're a harbinger. They're telling you soon you're going to get another episode and you're going to lose function. It's not going to come back. So when you get this warning, this is time for the patient to really seriously change his risk factors. Let's change the diet. Let's lower the sugar. Let's stop the smoking. Let's take care of all those risk factors for cerebral vascular disease and then hope it's not too late. Hope it's not too late because a lot of damage may be done, but a lot of atherosclerosis is potentially reversible. So that's a good thing. Might get that HDL up and it'll start cleaning your arteries. Now, this is going to bring us to stroke, and that's basically when you lose function and it don't return. Another name for it is cerebral vascular accident. Now, this is a neurologic deficit of cerebrovascular cause, so it's not due to MS, because you can lose function from MS too. That's a demyelinating disease. Now, this is due to blood flow, and it persists more than 24 hours, so it's basically stable over time, and it's due to a disturbance in the blood supply. It's not due to demyelination. Now, in terms of stroke, I mentioned 85% are ischemic. They're going to lead to these infarcts, versus about 15%, which are going to be hemorrhagic. Now, again, they're less common, and they're very lethal, those hemorrhages. And by the way, this is also an important decision point. If there's ischemia but no hemorrhage, then you can use thrombolytic agents or thrombectomy. You can go ahead and move it. If it's ever hemorrhagic, don't want to use thrombolytic agents because it'll bleed more. More bleeding, the worse it is. Now, you got to find the bleed and stop the bleed. That's what you want to do for hemorrhagic ones. Now, for ischemic strokes, the causes are things like emboli, thrombosis, either arterially or venous. Those are kind of rare, but if somebody has meningitis and they thrombose their veins, that can cause VT infarction too. And of course, hypotension. Severe hypotension can give you a stroke as well. Now, in terms of hemorrhagic ones, we've covered a couple of these already. Epidural and subdural are always due to trauma. Now, pretty important, they can all be caused by trauma. All of them. All of them. The last two are almost always trauma. So these are almost always trauma. Now, intracerebral hemorrhage can be caused by trauma, but it's more likely going to be caused by things like hypertension. Hypertension, yeah, boom, 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 psh, and then wind up with a bleed in your brain because of the rupture. The pressure leads to high pressure and rupture of the artery. And then a subarachnoid hemorrhage can be due to trauma, but it's going to be due to berry aneurysms, usually on the USMLE. Berry aneurysms. Okay, so these are like some of the important causes. Trauma can cause all bleeding in the brain. All bleeding in the brain, outside the brain, anywhere in the brain. But the first two, hypertension and berry aneurysms, are likely for the exam. All right, now let's start with the ischemic ones first. It accounts for most strokes. Now, if it's global, well, that affects the whole brain. Or is it focal? That affects just one part of the brain. Now, for global cerebral ischemia, another name for it is diffuse ischemic or hypoxic encephalopathy. Not good to have my whole brain having widespread hypoxia. And this is usually due to severe hypotension. That's when your blood pressure is really low, less than 50, or somebody's heart actually stops and then you resuscitate them, or somebody in severe shock. Now, neurons hate hypoxia. They're going to die first, especially the pyramidal cells in the CA1 region of the hippocampus. We call this summer sector. So again, if they like this kind of question, if there's an experiment and they go in the lab and they cut off the blood supply to the brain of a dog, and then they ask after 5 minutes, where will I see the ischemic red neurons? Remember, Superman dies under a red sun, and your neurons die as red neurons. Well, if you ever have that question, remember the hippocampus. Hippocampus. Now I remember, oh, that's memory. It's the memory area. So this is the most important. It's the most susceptible to hypoxia. Now in the cerebellum, it's the Purkinje neurons, the Purkinje cells. So cerebellum, Purkinje, the cerebrum, you want to think the CA1 gyrus, which is the hippocampus, part of the hippocampus, it's summer sector. Now, we can also have focal infarcts in the watershed areas. Okay, so ischemia affects these neurons first, but in terms of actually getting an infarct, the watershed area, that was the area between the anterior cerebral and the middle cerebral distribution. Now, the outcome. It's not good to have the whole brain ischemic, but it's really going to determine the severity based on how long it was and how severe it was. So really, that's going to determine what kind of deficit you get. So if it's really mild and very short, well, you'll get very confused. You won't be able to think properly because your brain's not getting perfusion. But in most cases, if it's really mild, you can have complete recovery. Now, at the other end of the spectrum, you can have really severe long-term ischemia, and that can lead to a persistent vegetative state. So basically, you're on a mechanical ventilator, and they got to decide whether they want to pull the plug. They'll look for brain death, lack of electrical activity. So that's not good. So it can go from anywhere from mild, if it's short, to killing you, being lethal. You got a respirator, not good. Now, much more likely on the exam is going to be focal cerebral ischemia. So it's a focal area of the brain where the artery is getting occluded. Now you're getting in that area, you're going to get damage. And that's why, number one, students hate this. And number two, it's so much fun. Because you got to know based on the symptoms where the lesion is. It's like being a detective. You have this symptom, this symptom, this symptom, find the lesion. So you need to know where the arteries go, so you know what they're supplying and what will be lost if it gets blocked. Yeah, it's like a detective. And in med school, students really don't like it. Now, luckily, you had Dr. Mike Lanu. The guy is awesome at. He's the rock star. You were trained by an excellent neuroanatomist, so I know you know your neuro really well. But most students are poorly trained in neuroanatomy, and therefore this becomes a very difficult topic. So we'll try to make a cheat sheet to remind us some of the strokes and some of the classic features, so we should be able to recognize where the lesion is. Okay, because whatever the occlusion is, it's going to lead to ischemia and infarction in that artery distribution. So we need to know the symptoms. Now, these occlusions can be arterial, they can be venous thrombosis, or they can be due to emboli, usually coming from the heart or the carotids. They can have atherosclerotic plaque in the carotids. Now, here are the four major causes of ischemic strokes. And again, there are other causes, but these are the four biggies. Now, the first one is an arterial thrombosis. Usually, these are due to atherosclerosis. So first you get atherosclerotic plaque, then the plaque ruptures. When it ruptures, you get a clot. You get a clot on top of it. So this is a thrombosis over ruptured plaque. So the risk factors for this is going to be the same risk factors as for an MI. Same risk of atherosclerosis. So hypertension is a big one, but of course diabetes, cholesterol, obesity, inactivity, all the risk factors we talked about. Now, where are the most common sites for thrombosis? Well, the carotid bifurcation, so the carotids, the middle cerebral, that's a common site, middle cerebral, and the basilar. Now, wait a second, the basal and the carotid, these are big arteries, exactly. So these can be often be lethal, like the basilar thrombosi, those are often going to kill you. Not a good thing to have, these big arteries being occluded. Now, these tend to produce white or anemic or bland infarcts. They're really pale, no hemorrhage, no hemorrhage. So could I use thrombolytics here? Absolutely. Thrombolytics, if the CT shows it's anemic, it's bland, there's no hemorrhage, you can try thrombolytics to try to bust that clot and try to get some blood back to the cells that are kind of borderline. You don't, should I stay or should I go now? Should I die or should I not now? Well, if I get them some perfusion, maybe they'll decide to stick around. That would be a good thing. All right, now embolus is very tested. They love emboli going to the brain. And where's it coming from? Well, it's usually coming from the heart. So a clot in the wall that's breaking off. Now that clot could be on the valve, that could be a vegetation from infectious endocarditis. It could be on the wall, mural thrombosis, like after an MI. After an MI, the wall's not moving, and it's releasing dead tissue factor. So tissue factor, you're going to start clotting. What else? You can have atrial thrombi. Yeah, that's from AFib. So the atria is fibrillating, it's not moving, it's not contracting properly. You're piloting Burkhouse triad. So very common for AFib after several days to give you atrial thrombi, which can thromboembolize. And then this is an interesting one, paradoxical evidence. Remember, if you have a deep vein thrombosis, this is in the venous side. So this should go to your heart, then it should continue through the heart to your lungs. That's where it should go. You should get a pulmonary embolus. That's normal. Venous clot should go to your lung. But what if you have a hole in your heart, like a patent foramen valve? Well, then when it gets to the heart, it can cross across to the arterial side, and that can go to your brain and cause a stroke. So again, this is kind of a paradox. How the heck can it get from one side to the other side? And it was your case, right? Nice. Yeah, I thought they would be very rare, but they do occur. Paradox limits. And if you're the student who picks it up, you're going to look like a rock star in the wards. Now remember this: a paradoxical embolus. Look for patent foramen valve. Look for atrial septal defect. Look for some sort of hole in the heart. All right. Now another common site would be atherosclerotic plaques, which are breaking off and embolizing from atherosclerosis in the internal carotid. So always check the carotid, get an ultrasound, look at the carotids, because that could be a source for a little emboli as well. All right, now what is an extension of the carotid? Because coming up the carotid, what's an extension of it? The middle cerebral. It's a direct extension. So the most common site for an embolus is the middle cerebral artery, because it's literally a direct connection. It's a straight shot from the internal carotid right to the middle cerebral. So that's where most of them go. Again, it could hook turns and go to the anterior, but that's just less likely. Most likely go to middle cerebral. So notice, atherosclerosis can affect the middle cerebral, and so can emboli. Middle cerebral, common site for infarcts. Now, when you do get an infarct due to an embolus, though, it's usually red, hemorrhagic. Now, wait a second. This one's white and pale, and this one's hemorrhagic. What's up with that? What's up? Well, I got a way to explain it for you. But before I do, just want to mention the other two causes here. As we mentioned, are severe hypotension. The watershed areas are a big risk. And of course, venous clots. These are usually people who had meningitis recently. So they basically scarred up. Well, they can scar the arachnoid and get increased intracranial pressure because you can't resorb CS out. But they can also scar and thrombose the veins too. So anybody with meningitis is at risk for venous thrombosis. And of course, you'll get an infarct because the blood can't get out of the brain. Blood can't come into the brain. All right, now why is this one pale and this one hemorrhagic? Well, there's many ways to explain it, but here's the way I like to use. All right, so here is the surface of the brain. Here is the gray matter, where the cell bodies are. Here is the white matter, where the axons go. So peripheral gray, and then here's the white matter. This is the gray-white matter junction. Now, infarcts tend to be, when they're towards the periphery, they tend to be kind of wedge-shaped, but never a perfect wedge. They're more round than wedged. But they're kind of a wedge. This is more rounded. It's not a perfect triangle. It's the brain's kind of soft. So it's kind of rounded. Now notice, I kill gray matter. Gray matter must die, because that's where the cell bodies are, right? You need a lot of oxygen. And then, of course, an extension of them is the axon, so they'll die too. So gray matter must die, and for fun, we kill some white matter too. But gray matter must die. Remember, gray matter must die here. Demyelinating diseases, that'll be white matter. But infarcts, they're going to kill gray matter. All right, now one I'm going to leave pale, and the other one I'm going to make hemorrhagic infarct. So again, wedge-shaped, hemorrhagic one, and pale one. Now for the pale one, I'm going to blow up the artery going to this area. Now this is going to be due to atherosclerosis. So there's my atherosclerotic plaque. I've got lots of tissue factor in here. So unfortunately, when you get this to crack and blood comes in and meets tissue factor, now it's going to start thrombosis. And that thrombosis is going to block the entire lumen. It's going to block everything. So downstream, there's no blood flow. So downstream, everything dies. And since no blood can get past, it's occlusive thrombosis. It's occlusive. This is going to be a pale infarct. Pale. So thrombosis is a pale one. And again, using thrombolytics, if you can catch it early enough, usually within the first 6 hours, you want to try to use thrombolytics. After 6 hours, it's like too late. Now question, when I do bust this clot, now blood's going to come in. So will it turn hemorrhagic a little bit? Yes, when you have reperfusion, you will get some hemorrhage here. Okay, so initially it's pale. When you give thrombolytics, don't be surprised if you now get a little bit of hemorrhage coming into this area. Remember, you're gonna save a lot of cells, but there will be some reperfusion injury. That's okay. Yeah, I want to save as many cells as I can. Those other cells that get reperfusion, they were gonna die anyway. So try to save some cells by busting this clot. Now let's talk about this hemorrhagic one. And again, there's a number of ways to explain it, but this makes sense to me. Here's the artery going to this area, and of course, this is an embolus. This is due to the heart having AFib, so it's leading to fibrillation. Or maybe there's a vegetation on the valve, infectious valve endocarditis. Or maybe you had an MI and you have a mural thrombosis. So mural thrombosis after an MI, vegetation from infectious endocarditis, and atrial fibrillation. These are classic causes. Now, it can also be from the carotids too. The carotids can be an atheroembolus. Well, in any case, this already has a shape. This is formed. It's already formed. So when it breaks off and embolizes, it's gonna kind of get wedged in here. It's gonna kind of wedge itself in the artery. It's just gonna get stuck in there. So here it is. Notice it's blocking most of the lumen, blocking most of this lumen. So there's my embolus blocking most of the lumen. So downstream, it's going to cause an infarct. Now, why is it hemorrhagic? Well, because it's never 100% conclusive. It's mostly blocking, but there's a little bit of blood coming around it. A little bit of blood is squeezing by it. A little bit of blood gets through this area here and this area here, and that's why they're hemorrhagic. Because it wedges itself in there, it blocks most of the way, but already has a shape. So it's not going to completely occlude it. So that's why they're hemorrhagic. Oh, and by the way, these are lines of Zahn. These are the lines of Zahn, so you know it's a real thrombus from the body before the patient died. Pretty good lines of Zahn. Hemorrhagic. Hemorrhagic infarction. Again, if it's hemorrhagic, you don't want to use thrombolytics. If it's hemorrhagic, do not use thrombolytics. Okay? Very good. All right, so the reason I did this is because what the board does is they say the patient died. That's it. They don't tell you what organ it is. They just want to know what's the risk factor for their death. Okay, well, we take a look. We see it's the brain. You got nice lateral ventricles here, nice basal ganglia. Looks good. And then over here, you see this ginormous infarction. Notice it's kind of wedge-shaped. Kind of. It's a little bit more rounded than perfect wedge, but it's kind of rounded. And it's killing gray matter. See the purple gray? Look, here's normal purple gray, and then here's the white matter in the center. It's so sad. Every time I say gray, I'm thinking Gray's Anatomy, and I'm thinking gray as in 50 Shades Gray. Gray-white matter junction. So anyway, this is an infarct because of the shape. It's killing gray matter. It's killing a lot of white matter too. So it's killing a lot of this white matter. So gray matter and white matter both died. This is an infarct. Now, it's clearly hemorrhagic. So if this is a hemorrhagic infarct, what caused it? Oh yes, it's an embolus. So what was the risk factor for emboli? Oh yeah, look for AFib, look for post-MI, mural thrombus, look for vegetations of leaflets, look for atherosclerosis of the carotid artery. You want to know the risk factors when they're hemorrhagic infarcts. Now, if I showed the same picture but it was pale, the risk factor would be atherosclerosis. Then it ruptures and you get a thrombosis. That gives you a pale infarction. All right, now here's an example of really bad atherosclerosis leading to thrombosis. Now, if we remember our coronary artery anatomy, cerebral artery anatomy, I'm thinking with my heart today. These are the vertebrals coming up to the basilar artery. This is going over our brainstem. And then, of course, we got the posterior cerebrals. Here's the posterior communicating of the circulus. Here's the carotids. Carotids coming up. Notice a straight shot from the carotid to the middle cerebral. And then going this way, we got the anterior cerebrals over here. Anterior cerebrals. All right, so this is our nice circular willis, and they like to show circular willis. They'll show it grossly. They'll show it with an angiogram. They'll show it with a CT angiogram, with an MRI angiogram. They really, really like showing this anatomy and then making sure you know which branch is which. Now, if we cut this thing open, cut this open, sure enough, we see this really bad atherosclerosis. That's what this yellow stuff is. See how thick the wall is here? This is all atherosclerosis. Now, if you look here, do you see there's a plaque rupture? How do I know the plaque ruptured? You see the hemorrhage in the wall. Hemorrhage in the wall. So blood came in, met tissue factor, and then the lumen got thrombosed. See the lumen's got thrombosis? See it? You see the little white here? That's the line of Zahn right here inside the clot. The white, which I just covered up. I think you can see a white line here going down like that. That's the line of Zahn right there going down. Line of Zahn. Now again, here is the atherosclerotic plaque. Notice the hemorrhage inside it. And then notice the lumen has been occluded by this superimposed thrombosis. So this is a really bad one. This is a basilar artery thrombosis. Well, that's a lot of your brain gets perfused from this. So that's not a good thing to have. Okay, now here's some other rare causes of emboli. So I showed you atherosclerosis. Now I'm going to talk about emboli. We talked about the heart and the carotids. But what about fat emboli? Who's going to get that? Somebody who's fat? No, then I would be at risk. No. It's femur fractures. Your long bones at this age are now fatty. When you were a child, they had bone marrow, but now they're fatty marrows. So when you have a long bone like femur fracture from a car accident or a sporting event, you fracture your femur, now you wind up with fat going into the bloodstream, and you're going to get widespread white matter petechia. Wow. Look at that. Look at the white matter. Petechia everywhere. That's from all those little fat globules coming up and causing blockages all over the place. So very, very classic picture. Now again, where do these fat globules go to? It takes a few days. It ain't gonna happen right away. So look for a history of I had a femur fracture last week, because it takes like 4 or 5 days. And then it will go to your brain and your lungs. So in the lungs, you're gonna get shortness of breath. In the brain, you're going to get confusion and neurologic symptoms. Your brain's getting clogged up by all these little pieces of fat. It's not cool. Now, in the bloodstream, it's also going to clot up your platelets. It just clogs them all up. So your platelet count, your circulating count actually drops down. So on their skin, there's going to be petechia too. Petechia on the skin. So I always remember, a couple of days after a femur fracture, the patient gets confused, they're short of breath, they suddenly have petechia. Think fat embolus syndrome. Think fat embolus syndrome. And again, to confirm this, on a biopsy, you can get an oil red O or a Sudan stain, either one, because they're good to pick up fat. So oil red O and Sudan stains will show me little fat globules. Because in H&E, you dissolve out the fat, so the fat really hard to see on H&E. You need to use an oil stain, oil red O or fat stain. What they usually ask on exam, though, is they give you all these clues: femur fracture, shortness of breath, confusion, and you're thinking fat embolus. Then they say, what would you see in the brain at autopsy? What was on the skin? Petechia. What's in the brain? Petechia. White matter, petechia all over the brain. So that's certainly been asked on the exam before, and hopefully they'll ask it again. Now, we talked about the paradoxalomas, where a DVT goes to a frame into your brain. And of course, tumors can embolize. Yeah, they can embolize to your brain. Now, here's an important thing. Whenever something comes into the brain, it usually gets stuck at the gray-white matter junction. That's where things tend to get stuck. They get stuck at the junction between the gray and white matter. So that's always important. When I say gray-white matter lesions, always think of something that's coming into the brain via the blood. So gray-white matter lesions, okay? All right, now what about a tumor from the heart? Well, a tumor from the heart could be a left atrial myxoma. Do you remember that one? It's in the left atrium. So benign tumor, in fact, it's the most common primary cardiac tumor in adults, but it's in a dangerous spot because it's myxomatous, it's gelatinous, it's like jello. And it's wiggle, 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 wiggle until a piece breaks off and goes to your brain, and then you die of a stroke. How much would that suck? Congratulations, you have a benign tumor, but it just killed you anyway. But it's benign, but it killed you. Oh, poo. So benign tumor, but dangerous spot, atrial myxoma. And of course, it can wreck your valve. It comes in like a wrecking ball. It's in the left atrium. All it wanted was to break your valves. All you ever did was wreck me with your terrible singing. Sorry. Is it too late to say I'm sorry? All right, now here's what happens in the brain when there's an infarct. So it's going to go through very similar sequence of changes as an MI. Remember the sequence? First we had ischemia, then we had necrosis, then neutrophils, then macrophages, then scarring. Similar is going to happen here. Now, how long does it take for neurons to die? 5 minutes. After 5 minutes, you start losing neurons. But when they actually die, you can't see it under the microscope until some time later. So in other words, even though the cell's dead, it doesn't look dead until usually 6 hours later. So somewhere between 6 and 24 hours after the infarct, I can see changes. So if you die from a stroke right away and you do an autopsy, the brain looks normal. You can't see anything. But if you live for more than 6 hours and then you pull the plug and they die, and you can start seeing changes. So ischemic neurons, they die like under the red sun. So you'll see they have diffuse cytoplasmic eosinophilia. Do you see how pink their cytoplasm is? Good gravy. Do you see how dark and purple their nucleus? That's pycnosis. That's a nuclear death. That's a dead nucleus. And do you see the vacuolation? See the swelling, the evacuation around these cells? So you got these perineuronal vacuoles with very pink cytoplasm. This is called a red neuron. Very, very, very classic finding of ischemic dead cells. That's what they look like in the brain. I guess it's kind of like coagulation necrosis, kind of, huh? Like coagulative necrosis of neurons, kind of. Now, if it's a hemorrhagic infarct, it'll look exactly the same, but you're going to add blood extravasation. So you'll see lots of red cells just percolate through here. If it's a hemorrhagic one, lots of red cells throughout the thing. Okay, now who's going to come in for a free lunch to eat these up? Medical students, I mean neutrophils. So it usually takes 1 to 2 days. Hey, same as an MI. Same as an MI, right? 1 to 2 days, pick pus. 1 to 2 days, pick pus. Neutrophils going to come in. Neutrophils coming on in. Now, they're going to start where the vas supply is still intact, right? If the blood vessel's blocked, can't come in. But wherever the vas supply is still remaining, they will come in. So if you take a look at this blood vessel, notice all these purple dots around it. These are all cells that are extravasating. They're coming out. They're coming out. And then notice they're going into the tissues. Now, it's hard for me to see at this magnification, but all these nuclei here, not all of them, but a lot of them are going to be neutrophils. So I really can't see it. So is it okay to go a little closer? Let me go a little closer, blow it up a little closer. Let me just erase this so it doesn't mess up. Okay, gonna go a little closer, and then you can see a little better now. Now do you see a little better? See the blood vessel, there's a neutrophil in it, and then they come out. You know, the segmented cells, neutrophils just percolating through, looking for these neurons to kill. So again, that's what you see for a couple days. A couple days, you start seeing neutrophils coming to the brain, and you're going to start eating stuff. Now, who follows them? Mr. Macrophage. Now, this usually takes more than 3 days. So 3 days on, that's macrophage territory. After 3 days, so 3 days on. So I always remember, first day, pick red neurons. Well, 1 to 2 days, you're going to pick neutrophils, you're going to pick pus. More than 3 days, you go from macrophages. Remember, they're going to start calling in wound healing. Yeah, but the brain can't really scar, can it? Not really, because there's no fibroblasts in the brain. But who will try to make a scar? Yeah, the astrocytes. We call it astrogliosis, or just gliosis. They're going to come in and they're going to create what they call a brain scar, gliosis. That's one of the important markers, by the way, because when neurons die, sometimes it's hard to tell that they're missing, there's not enough of them. But gliosis, look for lots of these supportive astrocytes coming in and reacting. They lead on a little bit of fibrosis, but it's not really a scar. It's the best the brain can do. So again, after 3 days, predominantly these are macrophages. Now they're harder to see. I wish we went closer, but these are more round nuclei. They're more round, and they're bigger cells with more cytoplasm. These are all your macrophages, just having a free lunch. And notice the neuropill is kind of breaking up, isn't it? It's a lot of white spaces in here. So this brain is starting to break down, and soon you'll be left with a hole. So after several months, 2 to 3 months or more, so I should put 2 to 3 months and more, This is an old remote infarction. Now you'll see tissue loss because it's all been liquefied and eaten and destroyed. And you'll just see residual gliosis. So if we look at this area, it's very pale. Very pale, lots of holes. Do you see the holes starting to form here? So grossly, this is going to become a cystic space. So later on when they say, you got a hole in your head, they ain't kidding. You really do. So this is going to be left with a cystic space over time because all these areas just getting resorbed and eaten up and liquefied. And eventually these cystic spaces become a big hole. And when it starts out small, they call it a racooner infarct. Then it gets big, it becomes a cystic area. I'll just show you a picture real quick. Here's what it looks like grossly. Now, again, the first day you're not going to see much. The tissue becomes very pale and soft and swollen because of edema. Only thing you might see is like it's hard to tell the gray white matter junction. It starts becoming indistinct. Okay, so initially, not much to see, pale and soft. 2 to 10 days, the brain now becomes a little gelatinous and starts looking friable. Looks like it's falling apart. And then sure, 10 days to 3 weeks, it's all liquefying now. It's literally breaking up and cystic spaces are starting to occur. And then after 3 months, this is an old remote infarct, you're just gonna have a fluid-filled cavity. See this area here? This is just a fluid-filled cavity. There's a little bit of connective tissue here, a little bit of scarring, but it's mostly empty space, really. You don't really get good scars in the brain. This is gliosis. All right, does it make sense? Now, good news. Not so easy to test this because it's not exact. But I certainly will remember after several months, it's a fluid-filled cavity. I remember initially one of the first findings is loss of the gray white matter junction. So that's what I remember. Initially, it's pale and soft with loss of the gray white junction. Then later on, it becomes a cystic cavity. But again, not very testable in terms of should I memorize all these times? No, it's pretty similar to an MI. But under the microscope, they're more likely to ask about these changes. Red neurons, then neutrophils, then macrophages, then scarring, gliosis. Same pattern we had in the heart. Just repeating itself. Okay, now let's talk about stroke diagnosis and treatment. We're docs. Diagnosis and treatment is what we're all about. Now, to diagnose, we certainly want to have a history. What happened? What symptoms are you getting? Because that's going to help us find the lesion. You know, like a detective in neurology, it's really like finding the lesion. So doing a history and a focused neurologic exam to determine where the actual deficits are is critical for locating it. And then, of course, imaging is critical as well. So CT without contrast, you don't need a contrast for acute bleed. Acute bleed lights up. You don't need contrast. Or an MRI, both of these are very good at diagnosing. Now, we also want to look for the reasons, the source of emboli. So we'll do a Doppler ultrasound to look for carotid stenosis because atheroemboli is our major cause of transient ischemic attacks and strokes. We want to do an angiogram if we suspect that there may be an aneurysm, like a baryaneurysm, or maybe an AV malformation, because those certainly can bleed. They're malformed blood vessels. So angiography of the brain, if the CT or MRI shows us something that looks like there may be an aneurysm or AV malformation. And of course, if there's any evidence of heart problems, you might want to get an EKG or maybe Holter monitor to look for arrhythmias like AFib. And you also want to get an echo to look for vegetations in the valves, to look for mural thrombosis, look for some sort of clot in the heart as well. Okay? So this is what we're going to start with. And then, of course, this is going to be used to work up possible etiologies. Now, treatment is very simple. Not much we can do for a stroke. What we try to do as quickly as possible. If it's ischemic, bust the clot. You better bust the move because time is brain tissue. Yeah, you got only about 6 hours for this to be effective. So you got to get the patient as quick as you can, get those thrombolytics. Now we're going to use the body's own mechanism. The body breaks up clots by using tissue plasminogen activator. That's what the body uses. So we're going to use a recombinant form. So this is called recombinant TPA. It's called alteplase. Alteplase. Again, I'm a terrible speller, so I spelled it wrong. Sorry. I think I spelled it right. Alteplase. This is the recombinant form of TPA. Now, if you can't do that, what if you don't have it? It's not available. Okay, well then you can also do a thrombectomy. You can literally go in there and grab it and pull it out. And they did this on House. They went in there, and of course, who did it? The residents did it. I'm like, what? Ridiculous. ridiculous scenarios. Good medicine, but ridiculous scenarios. And of course, they got it out, and the guy was great. All right, now that's ischemic. Now, what about hemorrhagic? Well, if I ever see hemorrhage on the CT or MRI, we definitely don't want to give thrombolytics. We want to detect where the bleed is and what the cause is, and try to treat the cause if possible. So if it's an aneurysm, maybe you can coil it or clip it. If it's AV malformation, you might be able to go in and also clip that one as well. So very important to try to detect the reason for the bleed and stop it. If their platelet count's low, get their platelet count up. If it's due to a coagulopathy, you want to treat the coagulopathy like hemophilia. Remember, hemophilia, the number one cause of death is bleeding in the brain. Number one cause of death is a hemorrhagic stroke, intracerebral hemorrhage. So very important to look for reasons that the patient may be bleeding in the brain. All right, now we talked a lot about ischemic ones, but I also want to talk a little bit about hemorrhagic ones too. Now, hypertension is a risk factor for both, because we know hypertension is a major risk factor for atherosclerosis, right? That's one of the biggest risk factors for atherosclerosis, which can lead to infarctions, ischemic strokes. But hypertension also affects the small vessels too, the small, deeper, penetrating arteries and arterioles. Do you remember the term hyaline arteriolosclerosis? Yeah, it's because where is the resistance to blood pressure? It's in the arterioles. So hypertension pounds them and pounds them and pounds them. When they get damaged, now protein's going to leak into the wall chronically. So you're going to see hyaline, pink change, and thickening, sclerosis, hyaline arteriolosclerosis. Yeah, this is the answer whenever asked what's wrong with the small vessels in the kidney or brain of a diabetic or hypertensive patient. Diabetes and hypertension, hyaline arteriolosclerosis. Now, clearly the lumen is narrow, so it's going to give you ischemia, and it's more likely to get occluded too. Now, for hypertension, which arteries are affected? Well, it's usually going to be the smaller arterioles, which are deeper in the brain. They're basically going to the basal ganglia, the hemispheric white matter, the deep white matter, and the brainstem. Okay? So atherosclerosis usually affects the more superficial vessels of the cerebrum, but hypertensive pathology, which is the hyaline arteriolosclerosis, usually affects the smaller vessels. And of course, once it's weakened, now you can get these minute aneurysms. Yeah, they give a fancy name. They're really small. They're less than 15 millimeters. We call them Charcot-Bouchard microaneurysms. Yeah, these little aneurysms, and obviously they can rupture and bleed. So hemorrhage. So hypertension can give you hemorrhage. Hypertension can give you occlusion of small vessels. And of course, hypertension can give you atherosclerosis of large vessels too. It affects all the vessels. All right, now let's talk about some important effects of the brain, hypertension on the brain. Well, hypertension can cause infarcts, small ones, lacunar ones, and it can also cause atherosclerosis, which gives you bigger infarcts of the cerebrum. Okay, so small infarcts in the brainstem, big infarcts in the cortex. What else can hypertension do? It can bleed. Small bleeds, you get slit hemorrhages, or you can get big bleeds, intracerebral hemorrhages, which will kill you. And then finally, malignant hypertension will pound your brain. It's a medical emergency. It'll pound your brain will swell up from all the pressure, and you can herniate. So this is very dangerous. Hypertensive encephalopathy, you gotta get that blood pressure down quick. This is malignant hypertension, that's an emergency. So we'll do all four of them in this order. We'll go through them one at a time. Okay, let's talk about small infarcts, lacunar infarcts. Lacuna matata. No worries, they're small. Yeah, but they're in dangerous areas. So they may be small infarcts, but brainstem is an important area. So lacunar infarcts, they're single or multiple. They're small, usually less than 50 millimeters. And they look like little cavities, little infarcts. And it liquefies and becomes a little cavity. So if we take a look at this pons here, notice these little holes. You got holes, dude. Holes in your brain. Yep, this is the pons. So these are nice little cavitary infarcts, little lacunar cavity infarcts in the pons here. And this is basically occlusion of these small penetrating arteries because of hyaline arteriolosclerosis. sclerosis. Yeah, get really narrow. Now, if they ask you, where's the most common artery to give you basal ganglia lacunar, you're going to say the lentico-striate branch of the middle cervical artery. I made it red because they seem to like to ask this, because this is the most common site to get lacunar infarcts, basal ganglia. So that's the most common site. So lenticular-striate artery. That's what's most likely to be involved. But you can also get these in the thalamus, internal capsule, deep white matter, pons, just like I showed you here. So all these areas, it's these deeper areas that are important here. Now, what's it going to cause? Well, it really depends on where it is. Location, location, location. That tells you what symptoms you're going to get. So they can range from silent clinically to severe neurologic impairments, which can actually kill you. If it's in the medulla, you can actually die. So it really depends on the location. Now, question, if you have a lot of them, you can develop what's called dementia, vascular dementia, multi-infarct dementia. So let's repeat. If I just have one, I'll get local neurologic problems. But if I have lots of them, in the gray matter, white matter, basal ganglia, then you can get what's called multi-infarct dementia. And this is the second most common cause of dementia. The number one cause of dementia? Alzheimer's. Alzheimer's is number one. Alzheimer's accounts for 60%, 60% of all dementia. So Alzheimer's is number one, and this is number two, multiple infarcts. And again, these are multiple bilateral. They're involving the gray and white matter, and they're basically infarcts. It's going to give you not just dementia, but you're going to get multiple problems because you have multiple infarcts. So gait problems, pseudobulbar, like difficulty swallowing, chewing, emotional lability, all of these things can happen. And of course, the key distinguishing feature here is Alzheimer's is a gradual onset dementia, insidious. This is going to be stepwise, right? Boom, I had a stroke, so overnight I got a symptom. And then another few weeks later, boom, another. So this is going to be like step down, step down, step down. So this is not like a gradual, slow thing. This is each time they get an infarct, they're getting worse. So this is multi-infarct vascular dementia. All right, now let's talk about what this picture looks like. I should have showed this earlier when I was talking about hyaline arteriosclerosis. I just forgot to show it. So here's a nice example of the brain. And notice these arteries are thick and pink. Aren't they thick and pink? Let's look at a little closer. Let's go closer. Look at how thick this wall is. These are not very big vessels. Look at how thick the wall is. Now, is it alive or dead? Is this fibroid necrosis? Well, oh no, I see nuclei here. I see nuclei. So it's just a really thick wall because it got damaged by the pressure. So proteins leak into the wall, and the wall gets really, really pink because of all the proteins. Well, guess what? Once this wall is now weakened by all this protein, now you can get little aneurysms. That's the Charcot-Bouchard's aneurysm. Yeah, and of course these eventually can rupture and bleed. So these are the changes we're looking for hypertension. Hyaline arteriosclerosis leading to little microaneurysms. All right, now here's the second of the hypertensive disorders, slit hemorrhages. These are like, they look like slits because they're little areas that rupture and get a little shoot of blood. And then basically that area is damaged. Neutrophils and macrophages come in and eat it up, and you're left with a space. But this is going to become a slit-like space. So again, this is rupture of the very small caliber penetrating arteries. And basically the hemorrhage starts to get eaten up as well as the brain. And you'll get these slits. So you have a hemorrhage like that. And when it resolves, it gets eaten in the middle, it becomes a cavity, which is kind of slit-shaped. And at the edges, you'll see a little brown. Yeah, that's the old blood. That's the hemosiderin. So they call these slit hemorrhages. So first you have a hemorrhage in a linear fashion, and then the body goes in and breaks all that down. So you'll have a slit-like cavity surrounded by brownish discoloration from all the hemosiderin. So this is like a lacuna infarct because of hemorrhage. So it's kind of like. All right, now this is an emergency right here. Acute hypertensive encephalopathy. Medical emergency. Call the med student. We need somebody who knows what they're doing. Quick, quick, get the med student. All right, this is an important one. I'm just trying to increase, there you go. exhibiting. All right, this is due to malignant hypertension that's pounding the brain. So now the pressure goes up diffusely. You're going to get papilledema, headache, projectile vomiting, visual problems, sometimes even coma. So you're actually getting cerebral dysfunction because of this high pressure in the brain. So you need rapid intervention here because soon your brain will develop a bleed or you'll herniate. Either one. Malignant pressure can cause an intracerebral bleed, or the pressure goes up so high you herniate. So this is an emergency. We got to get the blood pressure down quickly. Now, do you guys remember the DOC? What is your DOC for malignant hypertension? Well, we want to use IV, get in there fast, nitroprusside. I know that's what you're typing. So nitroprusside. Yep. Now, do you remember how it works? Every drug, know your mechanism. Yeah, this is gonna, do you remember the mechanism? No? You don't remember? No? Oh, good, because it's nitric oxide donor. It donates nitric oxide, which increases cyclic GMP, and that causes relaxation of the arteries and the veins. Gets rid of preload and afload. Arteries and veins both relax, and that really drops your blood pressure quickly. That's cool. That's cool. Oh, and by the way, in addition, toxicity, cyanide. So we can't use this for high dose for too long. And please do not leave it on a windowsill because sunlight will convert it to cyanide. So nitroprusside should be kept in the refrigerator in the dark until you're ready to use it because it gets converted to cyanide. Would mannitol be helpful? It can be. It can be to try to lower pressure rapidly because that'll suck the fluid out of your brain. But again, it really won't change the pressure, the hypertension, right? So the underlying hypertension will still be there. So it's like, kind of like bailing out a boat when there's still a big hole. It's kind of better to plug up the hole. So getting the blood pressure down is much more important here. Now, if we have increased intracranial pressure for other reasons, mannitol right away. But we know the reason here is hypertension, so we address the hypertension first, and then if that is not sufficient, mannitol will be next. Ryan gets the gold star. Good job. All right, now, autopsy. If we don't work fast enough and the patient dies, we're going to see a swollen brain. That brain could have a herniation, transtentorial, remember the uncus goes over the tentorium, or a tonsillar. Oh, that's the worst one, where the tonsil cerebellum going to the foramen magnum and just stop breathing. So that's one of the problems here, is that pressure can herniate you. And of course, we're going to see petechia because high pressure is going to cause little bleeds. You'll see flame hemorrhages in the eye. You're going to see petechial hemorrhage in the kidney. They call it flea-bitten appearance. And you'll see petechia in the brain too. I want you to look for fibrinoid necrosis of the arterioles. Fibrinoid necrosis. Yeah, when I see this, there's always two answers. Fibrinoid necrosis is either malignant hypertension or an immune disease, immune damage. So again, either malignant hypertension or an immune disease. And that's all I'm picking when I see it. So if it is immune disease, can you have vasculitis in your brain? Yeah, lupus. Lupus vasculitis is going to lead to a stroke, a hemorrhagic stroke on the exam too, because that can cause fibrinoid necrosis, weakening of an artery, and blood can leak out. You bet. So malignant hypertension can bleed in the brain, lupus can bleed in the brain, any vasculitis involving the brain. Now, here's what it looks like. Let me outline the artery wall for you here. It's a small arterial, actually. We're really close on this picture. So here it is. Here's the wall. Here's the lumen in here. Okay, so this is where the blood should be. This is the lumen, and this is the wall. Now, in the wall, I don't see any purple dots like I did in the other picture. I don't see any purple dots. I just see pink dead stuff. So this is fibrinoid necrosis because the wall died from the high pressure, and then fibrin and other proteins leak out, and that's what looks pink like fibrin. So they call it fibrinoid necrosis. Fibrinoid necrosis, dead and pink. If we go back, take a look at this. Notice this wall looks really pink too, but I still see nice purple nuclei. I still see nice nuclei. So that's the difference between necrosis, which is pink, dead and pink, and hyaline arterial sclerosis, which is alive and pink. All right, perfect time to take a break. When we come back, we'll talk about intraparenchymal or intracerebral hemorrhage, where you're literally bleeding inside your brain because of high blood pressure. Oh, you popped an artery. Now you're going to bleed in the brain. By the way, small artery, but big bleeds because arterial pressure is really high. So these are smaller vessels, but you get these giant bleeds. All right, let's take a break. I'll see you guys in a few minutes.
see, my, so it's Easter this weekend, and my parents were wondering if I was going home. And I said, probably not. And my dad said he might just drive down one day on the weekend.
Do what?
Dinner, and then drive back.
Do what? Why?
He did this in college too, like, you know, like I don't mind, but I mean, it's just like, it's not, I wouldn't do it with my kids. It's a lot of driving.
Pretty far.
Yeah, it's like 6 hours total driving. No, actually, it's about 8 hours total driving. I'm like, you don't have to. He said, well, I'm in the boat. Yeah, part of the boat. He did it in college too. Like, he'd come down like a football game on Saturday and leave after the game.
Huh.
Like after our lunch or whatever. Thanks. You know. Also, my parents told me that they were definitely not coming to the banquet.
Well,
Do we have to go?
no.
They're not going. Didn't you say your parents aren't going? Do we have to RSVP by now?
I think we have to leave on. Same feeling. He's always going. And always going. Starting to get some of those.
Alright. I didn't know if anybody was gonna go. If you guys are going, I guess I'll RSVP.
It's good. It's good dinner.
I remember it not being good though. What was that?
I remember a really good cut of filet.
Really?
Cooked
I remember
really well.
really bad cut of plate. Like, I remember like, having half my steak on my plate, thinking I couldn't eat it. It was too cheap.
Remember thick, supple, medium rare.
I haven't had a steak in forever. Let me get that.
I haven't had a steak in 4 minutes. I am a banana.
Kevin's thinking of the real brain duster.
Okay.
I don't know what happened to my advice, but I can't feel this.
No, be back.
Okay, gang, hour number 2, so far so good. Cerebral vascular disease. Man, this is a big topic. So much to remind ourselves of. We gotta go back to hypertension. We gotta go back to arteriolosclerosis, fibrinoid necrosis, autoimmune diseases. Man, lots of things can damage blood vessels and cause pathology in the brain. Now, here's a biggie. It's only about 15% of all strokes, but high pressure, man, arterial pressure can cause herniation. So very dangerous to have bleeds in your brain. So these are called intraparenchymal or intracerebral hemorrhages, right there. So it's bleeding inside the brain. And notice the way it bleeds usually in the basal ganglia, because that's where hypertension usually affects, the basal ganglia, brainstem, or the deep white matter, which is the centrum semivalve, deep white matter. Notice peripheral gray is usually spared. Peripheral gray is pretty spared. Yeah, great. Christian gray. Usually spared here because it's out towards the periphery. So infarctions usually get peripheral gray, but bleeds usually more in the basal ganglia or the white matter, the centrum semivalve, more in this deeper area, because that's where hypertension usually affects. Now you can also have lobar hemorrhages, and we'll talk about the reason for those in a second. But take a look, this is a beautiful picture. You might see this one again on exam. That's a hemorrhage. Look at the blood in the brain. Now again, we can bleed above the brain, just a little bit up in the subarachnoid area. That's called a subarachnoid hemorrhage. You can bleed in the subdural area, below the dura. And then you can bleed above the dura next to the skull. So these are the places we can bleed. We can bleed inside the brain, we can bleed in the subarachnoid, subdural, and epidural space. Now, do you remember epidural? You had a lucid interval of maybe 1 to 4 hours, because that's arterial pressure. That was the middle meningeal artery. Then we had the bridging veins. Bridging veins are going to give us the subdural. That one had maybe 24 to 48 hours. It may take a long time before it actually builds up. And again, in most cases, it will be more quicker, but it could take time. Lucid interval is much longer. What do you think the lucid interval is for bleeding inside your brain? So this is venous pressure, this is arterial pressure, this is arterial pressure inside the brain. Lucid interval here is maybe 30 minutes. Then you get neurologic problems, hernia, die, go into coma. So not much time here. These bleeds, if they're big, they're going to kill you, and they're going to kill you quick. Not a good thing. Not good. All right, now, as I mentioned, these intracranial hemorrhages account for about 15% of all strokes, and here are the places you can bleed. Intracerebral, which is better intraparenchymal, because aren't they all inside the head? All right, so intracerebral is better known as intraparenchymal, subarachnoid, subdural, and epidural. Now, these two we covered already in the trauma section. Now we're going to cover these two. Okay, now a spontaneous intraparenchymal, intracerebral hemorrhage. These are going to be peak incidents, usually older people, and it's rupture of the small intraparenchymal vessels. Now, it could be the small vessels in the basal ganglia area. Those are called ganglionic hemorrhages, basal ganglia thalamus area. And then lobar is the cerebral hemispheres. Those are called lobar bleeds. So ganglionic is basal ganglia bleeds, and lobar is in the cerebral hemispheres. Now, the reason they broke these up is because there's usually different causes. For instance, the major etiology for bleeding in the basal ganglia area is hypertension, because it affects the small vessels in the deep areas of the brain. So it's going to be most common cause of a parenchymal hemorrhage, usually in the basal ganglia area. In fact, the most common is the putamen of the basal ganglia. That's the most common site to have a bleed. Now, it can also occur in the thalamus, the pons, and the cerebellum as well. Now, the reason for this is hypertension weakens those vessels and gives you Charcot-Bouchard's microaneurysms. They're most common in the basal ganglia, and they're most likely to rupture there too. That's what's going on, basal ganglia. Again, that's the reticular striate artery. Now, what about bleeds in the lobar and the hemisphere? Well, that's usually due to cerebral amyloid angiopathy. Amyloid angiopathy. So pathology of vessels where amyloid deposits and weakens them. Now, wait a second. Isn't there amyloid in the brain in Alzheimer's? Yup. So this is often found in patients with Alzheimer's. So it's A-BAP. Remember the beta cleavage of the amyloid precursor protein? But that's why you get dementia. BAP, 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 BAP. Too much BAP depositing in your brain. Well, it can deposit and make these amyloid plaques, A-beta plaques, called senile plaques. But it can also deposit in the artery. And when it deposits in the meningeal and cortical vessels, it's going to weaken them. And when it does, you get lobar hemorrhages. So it affects kind of a different part of the brain. It's more peripherally, more superficial vessels are involved here. Okay? So again, when you see deep bleeds, think hypertension. When you see more superficial bleeds, we think amyloid angiopathy. By the way, do you have to have Alzheimer's to have this? No. It's often found in Alzheimer's patients, but we also see it occurring by itself. You can get amyloid angiopathy all by itself. Now, are there other causes of bleeding in the brain? You bet. Trauma. If I hit you in the head, you can bleed. Other causes are coagulopathies. The number one cause of death in hemophilia is bleeding intraparenchymal. Vasculitis, I mentioned lupus. They really like lupus involving the vessels of the brain. Yeah, so that's not a good thing, you can bleed in the brain. Tumors, they can bleed. And of course, malformations. We'll see a bunch of these towards the end of this chapter. We'll see a bunch of malformations that can bleed. All right, now again, location, location, location. If you see the hemorrhages more towards the hemisphere area, these hemisphere or lobar bleeds, you want to think about the amyloid angiopathy. And again, notice these areas, see the areas here that are involved? It's more towards the lobes, the hemispheres. Now the deep basal ganglia and white matter, these are going to be due to hypertension. And remember, they can get lacunar infarcts, they can get these slit hemorrhages, and they can get these bleeds here too. So hypertension really messes up these basal ganglia. And again, if you look at the imaging, you'll notice it's mostly in the basal ganglia areas. That's what you see in the hypertensive bleeding. So very important to know location, location, location. All right, now here's what it looks like under the microscope. Here's the amyloid angiopathy. So here's the vessel. Notice it's thick and pink. It kind of looks like hyaline arteriolosclerosis, does it not? That's what it looks like to me, because hyaline arteriolosclerosis is a pink, thick wall with protein. So is this. This is a thick, pink wall with protein too. So how do I know it's amyloid? You gotta give me the Congo red, because otherwise I'm gonna say hyaline arteriolosclerosis. So you gotta give that Congo red, and then notice the way the walls are lighting up red. Here's another example of a Congo red. Notice the walls are lighting up red. But again, that's not diagnostic. What's diagnostic is to do a Congo red, then to put it under polarized light. If I put it under polarized light and I see two colors, that's called birefringence, and one is an apple green, you get your diagnosis. So notice this area here is yellow, but what's diagnostic is this green area. See that? So two colors, birefringent, and one of them is this light apple green, pathognomonic amyloid. It only stains beta pleated sheets. So very important, amyloid's beta pleated sheet, and it lights up. And of course, this is going to weaken the wall. These vessels are now going to get very, very leaky because they're full of all this junk. Too much junk in the trunk. All right, now let's switch and talk about a subarachnoid hemorrhage, bleeding into the subarachnoid space, which is right on the surface of the brain. Now, this is the most frequent cause is a rupture of a berry aneurysm. Now, you call it a berry, I call it a cherry. It looks like a cherry to me, but the board calls it saccular. Arr! They love to use names that students are just not familiar with. So berry is what everybody calls them. For saccular, they think it looks like a sack, so they call it saccular. I think it looks like a cherry. Now, this is the most common cause of intracranial, it's the most common type of intracranial aneurysm. It's the most common intracranial aneurysm. And they're usually in the anterior circulation. Again, here's how we divide it. This is the anterior circulation coming from the carotids. That gives you your middle cerebral and your anterior. And the posterior is the basilar coming from the vertebrals, and that goes to the posterior arteries. So that's posterior versus anterior. And again, they're connected by the circle of Willis. But this is the anterior versus posterior. So most of these are in anterior circulation. And they usually have branch points, because that's where weakness occurs. Turbulence creates weakness. Look at this, 2% of the population has berries. A lot of people don't know it. A lot of people have multiple. So 20 to 30% of people who have them have multiple ones. Wow. Now, they're usually detected in the 40s and 50s, and males have them more than females. Now, when they rupture, you get the worst headache of your life. This is a thunderclap headache. It comes on really, boom, it hits you really hard. And they say it's the worst headache I've ever had. It came on, boom, like a thunderclap. Boom, worst headache ever. So what does a headache feel like? It feels like boom, 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 clap. The feel of my headache bleed goes on and on and on and on, and boom, clap, make me feel better. Come on, CT, come on, CT now. Get a CT for head trauma and for the worst headache of your life. Get a head CT. You don't even need contrast. Bright bleeding. Bleeding is bright. It'll light up. So bleeding looks bright on a CT. You don't even need contrast. All right. So worst headache of your life, it comes on very rapidly and very severe. Now, subarachnoid, this is going to give you neck stiffness, so pain and stiffness. Now, wait a second. Headache and a stiff neck. Doesn't this sound like meningitis? Headache and a stiff neck sounds like meningitis. So what if you did a lumbar puncture? What if you did? Well, if you do a lumbar puncture, there's going to be blood. There's going to be blood in the CSF. Yeah, but wait a second. How do I know if that blood is really in there or a medical student was trying to do a lumbar puncture and they don't know what they're doing, so they did a traumatic tap and they got blood in it? So is that real blood, or is that the medical student got blood in there because it's a traumatic tap? Well, if it's a traumatic tap, the first tube will be bloody, but then the second tube should clear up, and the third tube should be all clear like normal CSF. Well, what if they only got one tube? It's the medical student, they only got one, couldn't get more than one. All right, well, if you only got one, then what do? Spin it. Spin it, because that will sediment all the blood. Now you look at the supernatant. It should be clear. CSF should be clear. It's going to look yellow. That's called xanthochromia. Xanthochromia. That tells me it's a real bleed and not a traumatic tap. Xanthochromia. Now, why does it look yellow? Why is xanthochromia yellow? Because if it's a real bleed, the red cells are going to break down to bilirubin. And we all know bilirubin is yellow. So it's going to turn yellow. That's xanthochromia. Now, very important. Should I ever do a lumbar puncture when there's increased intracranial pressure? Well, let's see. If I put a hole down here, then what will your brain do? You're going to suck the brain down. As the fluid comes out, leaves the pressure, your brain is going to herniate. You just killed the patient. So you can do a lumbar puncture, but first get a CT. First, get a CT, because if you see signs of intracranial pressure, you don't do an LP. You get a CT first, CT first. If the pressure's fine, sure, no problems. But if the pressure's high, you could potentially herniate the patient. So always CT first here when you get the worst headache of life or head trauma. All right, now these bleeds can give you rapid loss of consciousness, and look at this, a large percentage die. Now I hate numbers like this. I need to make it round so my brain can remember it. So here's what I'm gonna remember. Rule of 1/3. 1/3 die. I don't like that. 1/3 recover. I like that. And then 1/3 rebleed. Ooh, I don't like that. 1/3 are we gonna bleed again? So what do you need to do? You need to find it and destroy it so it doesn't bleed again. Because you can prevent that rebleed if you destroy it. So again, we're going to start with a CT. And what are we going to see? We're going to see blood at the base of the brain. That's what the circle of Willis is. So on CT, worst headache ever, you get a CT and then the blood at the base of the brain. Sounds like a subarachnoid hemorrhage. Now, how do I detect where the bleeding is and find the aneurysm? Now you do a CT angiogram. CT angiogram, or just an angiogram is what we used to do. Now we do CT angiogram or MRI angiogram to really get look at the anatomy. But let's do an angiogram of some type to localize. That'll find it for us. Now, once I see it, oh, and by the way, when the blood comes out, the blood is now in this area. Well, what is it going to do because it's outside the artery? Well, it's going to irritate that artery, and it's going to spasm. You're going to get vasospasm, and that's going to cause stroke. This can lead to a stroke because of vasospasm. So to prevent that, as soon as I see this bleed on a CT, what drug am I going to put them on to prevent vasospasm from occurring? Remember calcium channel blockers? They were good for vasospasm of your hand. They were good for vasospasm of your coronary artery, Prince-Metal's variant angina. So very important, calcium channel blockers. Very good. Calcium channel blockers are important here to try to prevent that spasm. So again, I will do an angiogram to localize it, but once I see that there's a bleed, start the calcium channel blockers, then get the CT angiogram. Now when I see it, I'm gonna stake a catheter up in there, and I'm gonna fill it up with a coil. I'm gonna put a metal coil in it, because that will cause it to thrombose and scar up, so it will never bleed again. So we coil them. We put a coil in there and destroy them. Now, if you can't technically get to them with the wire, well, then what you need to do is open up the brain and clip it. So coil it or clip it so it doesn't rebleed. Don't you feel like a doctor now? Like you know exactly what to do. Start with the CT. You see the blood at the base of the brain. Start the calcium channel blockers and get an angiogram. Put the catheter in, coil it, and clip it so it doesn't happen again. because every time they bleed, about a third die. Not good. Now, notice what they did here in this picture. They turned the brain upside down to show you blood at the base of the brain. Blood right where the circle of Willis is. Blood at the base, there's the basal artery coming up here. So blood at the base of the brain, absolutely classic. Now again, to see it, I would use a non-contrast CT. Don't need any contrast at all. It will show blood at the base of the brain, bright, lights it up beautifully. Now, if we do a lumbar puncture, you'll see red cells in the CSF, and of course xanthochromia, which is a yellow color to the CSF if you spin it. Now, this rupture usually occurs when your blood pressure suddenly goes up. So what was the patient doing right before to increase their blood pressure, make it rupture? Well, what were they doing? What's going to increase your blood pressure? Making love. They were making love. Because if you're doing it right, there should be a sudden surge in pressure, and oh, you popped your cherry. You popped your cherry. I already determined that's the way I'm dying. I already predetermined my death. I am going out with a bang, a happy ending. That is how I'm dying. Yep. Hey, you gotta choose your way. That's the way to go out, right? Yeah, now what other illegal drug could they be taking that can also increase their blood pressure? How about cocaine? It's like sex and candy. Sex and cocaine. They have nothing to do with both of them, but either of these can do it. So patients using cocaine and patients who have just performed sex, blood pressure goes up suddenly, pop. That's when they pop. Now, they're usually associated with hypertension in the first place. So hypertension can lead to them. And then blood pressure goes up suddenly. Now, of course, on the USMLE, it's not going to be doing the naughty. On the USMLE, it's going to be strenuously lifting boxes, but you and I will both know what box is being lifted. Yep, it's some sort of exercise at night. Now, all of these clues, worst headache of your life, buried aneurysm is seen on angiogram, we clip it, there's blood at the base of the brain, there's xanthochromia, you're foaming at the mouth. You're like, this is a subarachnoid hemorrhage. Looks like meningitis. This is a subarachnoid hemorrhage. Worst headache, like boom, clap, thunder, hot headache, get a CT. And they're gonna ask you, what's wrong with the kidney? Well, what do you mean, what's wrong with the kidney? Well, wait, is the brain bone connected to the kidney bone? Yes, it kind of is. Do you remember autosomal dominant polycystic kidney disease? They had a connective tissue weakness in their kidney. So unfortunately, this weakness also is in the rest of the body too. So they get mitral valve prolapse, diverticulitis, and buried aneurysms. Now here's the good news. The board knows you know that, and they still ask it. They still ask it. So yeah, they're going to give you all these clues. You're going to know it's a subarachnoid hemorrhage, then that's what's wrong with the kidney. You say polycystic kidney disease. Now, in addition, connective tissue diseases that are weak, like RFANs, will be at risk. It's fibrillin problems, or Ehlers-Danlos, collagen problems. So these are some classic associations, genetic associations with buried aneurysms. Again, polycystic kidney is the most likely for them to ask. Very good. Now, does anybody remember the CT angiograms? You gotta take a look at them, because I can't do this for you. You gotta go to Google, click on image, and look at a lot of CT angiogram, MRI angiograms, because it's kind of hard to see the circle Willis. Like if I show it like this, everyone recognizes the drawing, right? You've seen this in Robbins, you've seen it in your textbooks. Everyone recognizes the circle Willis when it's drawn. But when it's an angiogram, students start having difficulty. So you better recognize it. And one of the students said, John, not only did they show me an angiogram of the circle Willis, but the question was, the patient is congenitally missing something. What are they missing? So he said, I had to realize it was the circle Willis, and I had to figure out what part was missing. I had to know where the basal artery was, I had to know where the posterior were, where the communicating was, where the middle cerebral, where the anterior communicating. I had to know where everything was. Oh, and by the way, what was missing? This one right here. Posterior communicating. You can live without that connection. It's helpful to have it, but you can live without it. So this is what was missing. Just congenital. The patient was fine. They just said they did a circle Willis angiogram, and they found something wrong. Something's missing congenitally. What was missing? And that was the cancer. We're missing that bilateral. Again, you look normal, no problems. Now, if you get into a car accident or you have occlusion of one of your arteries, you're not going to have the circles to help you. So that's not a good thing. But otherwise, you look normal. Okay, now where are the berries located most commonly? Well, we said anterior, but we didn't say exactly where. We're at the branch between the anterior cerebral artery and the anterior communicator. That's the most common site, number one. Number two site is middle cerebral. Middle cerebral, again, at the first major branch, always at branches because turbulence. So that's number one. This is number two. And then the third most common, again, is anterior circulation, but it's the carotids. Right when the carotid comes up, it's got all these branches, and they have it right at the beginning of the carotid right there. So that's the third most common. See that? So 1, 2, 3. So if this is the most common, you definitely need to know it. But you should also know the second and third most common as well. But here's the problem. If they show it like this as a drawing, they're going to turn it this way or turn it this way. They're going to orient it to try to mess you up. Or they'll just show it radiologically because students can't recognize what's what. Okay, make me impressed. Is this the first most common, second most common, or third most common? Which one is this one? You see the berry, right? This giant thing right there? That's the berry. Wow! Kevin, Evan, Mantis Toboggan, Rick James in the house. Bravo. So these are the carotids coming up. When the carotid comes up, boom, there it is, coming right up the carotids. Notice this over here would be the middle cerebral. Here would be the second most common site at this branch here. And then going here is the anterior. Here's the anterior going up this way. The communicator I can't really see, but it'll be in here somewhere. Some anterior communicator. There, that'll be the number one site right there. Bravo. Oh, I am impressed with you guys. So maybe you don't need any more help on your end. You guys are ready to rock and roll. Now, here's the way we treat these. We like to put a catheter in, and you snake in a wire, and you literally coil it in there. Just coil it, coil it, coil it, and you leave it behind. Just leave it in there, and it fibroses, it scars up, and it won't bleed again. So again, the preferred technique, if it's technically possible, is to put a coil in them. Now, if you can't get the catheter in there, there's some trouble, it's in a tricky area, then you'll have to open up the brain and clip it. You'll have to go in and put a clip on it so it won't bleed again. So coil it or clip it to prevent re-bleeding. Very important. Now, did anybody remember Sharon Stone? She was famous for the movie Basic Instinct. Remember, she's famous for the ice pick? No, she was famous for something else. But you remember the movie, right? Or maybe you're too young. Well, in real life, she came in with the worst headache of her life. And she came in the middle of the night. I wonder what she was doing. Maybe cocaine? Maybe. But she came in the middle of the night with the worst headache ever. They did a CT, and it was a subarachnoid hemorrhage. Now, for her, we didn't have, this is a while ago, we didn't have really good coiling techniques. So in those days, we actually opened her up and we clipped it. We clipped it so it won't bleed. So Basic Instinct 12, she will be back because no problem. She'll be a grandma still with the Basic Instinct. All right, so we clipped it. She won't bleed again. But of course, once she's stabilized, what should I always check her for? Always check her for underwear? No, we know she doesn't wear them. No, check her for polycystic kidney. Remember, you're Dr. House. You can't miss a genetic association. So check her for polycystic kidney, Ehlers-Danlos, Marfan's. Look for a reason that she might have had it. It's so much fun. Boom, clap. All right, now another thing that can bleed are vascular malformations. If you got funny malformed vessels in your brain, they're gonna bleed. They're gonna bleed. Now they can bleed inside the brain or they can bleed in the subarachnoid space, but they can certainly cause bleeding because they're abnormal. Now, they can also irritate the nearby cortex and lead to seizures. That's not good. If you're driving a car when you have your seizure, you can die from that. You can fall off a balcony or something. And then, of course, it can also give you focal neurologic deficits because the malformation may steal all the blood from another vital area. So if it steals the blood from somewhere else, well, that somewhere else will get ischemic and focal neurologic deficits will occur. but again, most likely to present with bleeding and seizures. Now, there are 4 types of vascular malformations. The first 2 are the ones that are clinically important and you need to know. The first 2 are the ones that get bleeding and seizures. The other 2 are incidental findings. Big deal, incidental only. I want to know the first 2, especially for exam purposes. So arterial venous malformation. That means the artery is supposed to go to a capillary and then to veins, right? That's what's supposed to happen. In an AV malformation, there's no capillary. You just go artery to vein, artery to vein. Well, that's abnormal. That's abnormal. So this is one of the most common malformations, and it's also one of the most dangerous because it commonly bleeds. Abnormal vessels can bleed. Now, you're going to see what looks like a bag of worms. It's basically a tangle of artery and veins. They're pretty decently large size. Now, they could be in the subarachnoid space. That's why I can give you a subarachnoid hemorrhage. And it can also extend into the brain, so I can give you intracerebral hemorrhage too. Be both locations. Now, it's more common in males, and it's usually detected in their teens and 20s. Now, they're going to present with seizures, or intracerebral hemorrhage, or subarachnoid hemorrhage. So it really depends on where it's located and where it bleeds. Now, another interesting possible presentation. Since blood from your heart goes into the artery and then immediately comes back in the vein without going through capillaries, it basically comes right back. So the heart's like, get out of here. Oh, you came back. Get out of here. Get out of here. Get out of here. The heart goes crazy trying to pump all this blood and it keeps coming back. So the heart basically goes into high output cardiac failure. So again, that's not common, but it can occur whenever there's a lot of AV shunting. And that's something very testable. That's kind of cool, that's unique. The other ones don't have that. So this could have high output cardiac failure because there's no capillaries into it. It goes from artery right to vein, back to the heart. Now, if you have multiple malformations, you might want to consider a genetic disease. Look for hereditary hemorrhagic telangiectasia. This is where you have an autosomal dominant mutation in the TGF-beta pathway, so you get lots of telangiectasias. Now, they're most common here on the lips, the tongue, and the fingertips. Well, guess what? Every day I use this. So it's going to bleed all the time. These are malformed vessels, they're going to bleed. So that's going to lead to iron deficiency anemia. And that's a favorite question about hereditary hemorrhagic telangiectasia. They're getting iron deficiency anemia. Well, guess what? They can also have these in the colon, so they can get bright red blood out of your rectum, put up with bleeding under rectum. And they can also be in the brain. Then they're in the brain, you're going to get bleeding. So seizures and neurologic problems. Makes sense, right? So this is a hereditary disease. We get telangiectasias. They're mostly in the skin, but they can occur in your GI tract and your brain too. All right, now here's what they look like. Normally, an artery should go to smaller vessels, and then to capillaries, then to venules, and then back to veins. That's what should happen, a long pathway. Now what we're having is this large artery gives to large arteries, back to large veins. There's no capillaries in between. So look at the blood flow, look at the size of these. This blood flow is going to quickly come back. That's pretty big vessels. Doesn't it look like a collection of worms? You can imagine it like, it's like spaghetti. It's like spaghetti vessels. So this is your AV malformation. And these vessels are leaky. They are leaky. They can leak and irritate the brain. Now here's what it looks like. Okay, if you take a look at this picture, I mean, this is a pretty big one, huh? Pretty big one. Notice these dilated vessels snaking through the vein. Looks like a bunch of worms. Don't look at this worm. Like dilated vessels, a bag of worms. Now here's what it looks like grossly. Again, dilated vascular spaces, dilated. And you notice all the brown tissue in here? Probably from bleeding. It's probably a lot of hemosiderin from all this bleeding. So this is a classic example of an AV malformation. And I'm pretty sure this picture or something just like it was on the exam because didn't know what the heck it was. Look at the vascular spaces. So if this was just one or two, I would think of lacunar infarcts. But look at, these are all blood vessels. Look at that, tortuous, you can follow them along. Tortuous vessels. So look at the way you follow this along, this vessel. Okay, so it kind of looks like lacunar infarcts, but these are vascular spaces. Okay, now here's a nice diagram of all four lesions. So we already covered AV malformations, these big dilated vessels, and they bleed. Now, when they bleed, that can lead to irritation and seizures. Who's going to come and eat the blood? Macrophages. So when this gets resolved, you'll see a bunch of hemocysteine macrophage there, and of course some gliosis. Gliosis will occur. They're just reacting to all this hemorrhage and bleeding. Now, the second one is also important clinically. See, these two are important because they're at risk for hemorrhage and developing seizures and other neurologic symptoms. So these are the two you better know, cavernous hemangioma. Now, the key for this one is back-to-back giant vessels, back-to-back, no intervening normal brain. So look, this one's got normal brain in between, this has normal brain in between, and these two are asymptomatic. These are just dilated vessels. Big deal. This one's like varicose veins. This is like dilated capillaries. No big deal. So these are incidental findings, even though you have them. So intervening brain, but these are giant vessels with no normal brain in between. And again, these bleed, so you'll see macrophages and you'll see gliosis as well. It's damaging brain. Now let me show you just go through the notes here. Cavernous hemangioma is the second, and it's the second most important of these malformations. You'll see those distended, loosely organized vascular channels, which are devoid of intervening normal tissue, just back-to-back vessels. It's most common in the cerebellum, but it can also come in the pons and subcortical region as well. Notice no AV shunting. So you only get that with the AV malformation. But it can cause hemorrhage, seizures, and focal neurologic defects. So that's why clinically it is important. You must know it. Now these last two, like I told you, are usually asymptomatic. They're incidental omits. You find them accidentally when you're looking for something else. So not that important. So capillary telangiectasias are just microscopically dilated vessels, and they're usually the pons, but don't cause any problem. And then venous angiomas are basically varicose veins in your brain. Varicose veins occurring in your brain. They're just ectatic dilated venous channels with normal brain in between. No big deal. Okay? Now, here is the one that was important, the cavernous hemangioma. Another name for it is a cavernous angioma or cavernous malformation, or how about this, cavernoma. Ooh, did you say Casanova? No, cavernoma. Cavernoma. I don't know, it sounds romantic to me, I'm not sure why. All right, here it is. Notice this very red area. I think there's been some hemorrhage here, probably. See these dilated spaces here, dilated spaces. These are the blood vessels. Under the microscope, you'll see they're very large, dilated blood vessels. See, the blood is the brown stuff. It's the blood inside them. And then notice, in between is just pink connective tissue. No normal brain in between. So it's just back-to-back dilated vascular channels with no intervening brain tissue. That's the key feature for a cavernous hemangioma. All right, another category is done. So bleeding in the brain, thrombosing of the brain, cerebrovascular disease is very, very high yield. Now, just to remind you, are there other things that can inflame my vessels and cause thrombosis? We talked about atherosclerotic plaques can do it, sure. But how about autoimmune vasculitis? Yeah, vasculitis. So we mentioned lupus, right? So vasculitis like lupus, that can have bleeds in the brain. But do you remember, Takasu, I can't take your pulse. Takasu, I can't take your pulse in the upper extremity head and neck. Yeah, you make my pulses stop. Ooh, so romantic, Takasu. Yeah, this is usually an Asian woman. She's usually reproductive age, and she comes in with loss of pulses and pressure here. So it looks like a stroke. So very important, young women don't have atherosclerotic strokes. So if you see a woman in a reproductive age, it's not usually atherosclerotic. It could be embolic, or it could be two weird diseases, TTP and Takayasu. TTP and Takayasu. TTP had the pentad, the low platelets, the neurologic, the fever, the microangiopathic with schistocytes, and of course the renal abnormality too. Remember, a stroke is not going to have renal failure. Okay, so that's very important to TTP from other diseases. Now, for Takayasu, it's a young woman who looks like a stroke as well. So TTP and Takayasu's are young women having strokes. Now, what you're going to do here is you're going to do an ultrasound, and you're going to see narrowing of the big vessels. And they're all narrowed. That's why there's no blood flow. Pulseless disease. In fact, you may have to put stents in to open it up. Now, it was due to granulomas. This was a granulomatous vasculitis. Granulomatous vasculitis, granulomas. Now, is there another vasculitis that involves the cranial branches of the arteries? Yeah, it's very similar. Takayasu's and temporal. They're both granulomatous. Temporal arteritis. Remember that one? That was an old woman who's DR4 positive, and she comes in with a throbbing headache, right? Pain, bumps, bumpy stuff. She'll come in with claudication of the jaw when she chews her food and visual problems. So ophthalmic artery, temporal artery, facial artery. That's usually what's involved here. And of course, if you don't start the steroids quickly and get rid of the granulomatous inflammation, she'll go blind. So very important to get the steroids on board for both of these, because this one can wind up stroking, this one can wind up losing your vision. So these are some vasculitis that involve the brain. All right, now what about infectious vasculitis? This is autoimmune, or females reproductive age, but what about infectious diseases? Do you know of any bugs that involve the brain? Oh, heck, man. There's a ton of bugs that go to the brain. So do you remember Mucor? Remember, it's angioinvasive. It gives you hemorrhagic lesions in the frontal lobe of a type 1 diabetic. Remember, it's got to be a diabetic ketoacidosis. Do you remember what Mucor looked like? It was very broad, no septation, and that 90-degree branching. So I call it the loser sign. M for Mucor, right angle branching, no septation. Another one that likes to cause a vasculitis in the brain is our friend Aspergillus. Aspergillus, again, not going to get this if you're healthy. You have to have AIDS or severe neutropenia. AIDS or severe neutropenic patients. Somebody with chemo, somebody with bone marrow transplant. You lose your immune system, now you get angioinvasive Aspergillus, angioinvasive. And of course, our friend Aspergillus branches at acute angles, like 45 degrees, acute. And it's got septation. Okay, so angioinvasion in the brain of AIDS patients, very hemorrhagic. So hemorrhagic because they both cause a vasculitis. Very, very good. How about syphilis? Does syphilis cause an endarteritis? Yeah, and syphilis, tertiary syphilis, that can give you lots of problems, not just in the brain, but also the spinal cord, tapes dorsalis, right? Very good. So there's lots of bugs that involve the brain. All right, now next category is our demyelinating disorders. So we'll start it here, and then we're close to a break, so we'll take a break. But there's 4 of them we need to know. And again, these are white matter problems, because you're going to lose the myelin, and now you're going to get neurologic deficits because no nerve conduction. We need myelin to speed up nerve conduction. If nerve conduction is slow, nerves really don't work. So this is a white matter problem. And there's 4 diseases of white matter. We have multiple sclerosis, which is an autoimmune attack. Your immune system is literally killing oligodendrocytes. We have progressive multifocal leukoencephalopathy, PML. This is due to the JC virus. So this is an infectious disease. It infects oligodendrocytes and kills them, so you lose myelin. And then there's central pontine myelinolysis, where the center of the pons has myelin lysis. This is because of an electrolyte imbalance. You tried to correct sodium deficiency too quickly. You never replace sodium. If some even live with low sodium, you replace it gradually. If you give them a big bolus of saline, you demyelinate the center of the pons. All right, so that's an electrolyte problem. It's osmotic. And then finally, we have a genetic disease or a group of genetic diseases that involve either the production, maintenance, or the breakdown of myelin. These genetic diseases are called white matter, dystrophy, abnormal myelin. And it's genetic. So this is going to be very young. This one's usually somebody who's homeless, they're malnourished, they're an alcoholic. This one is somebody's immunocompromised. This one is usually a woman in reproductive life, just autoimmune bad luck. This is going to be young. So that's the real key for this one. Young people with myelin problems, think about genetic diseases like leukodystrophy. Cool. All right, now of these, the highest yield by far is MS. You're going to see it. You're going to know people who had it. This is a very important disease, and it's fairly common. So it's devastating, too. So MS, how many letters is that? MS, 2 letters. How many systems? 2. 2 systems, motor and sensory. Motor and sensory. 2 letters? What HLA? TR2. TR2. So I kind of remember MS, 2 systems, motor and sensory, so everything's involved, and DR2. DR2 is increases the risk factor. And again, you get your immune system from your family. So if a family member has MS, well, there's a higher likelihood that somebody in the family could get it too. Doesn't mean they're going to get it, just means a higher likelihood. Now, the key for this one is your own immune system, we think, is destroying your myelin. It's basically demolishing the brain, the optic nerves. By the way, that's a very important common finding on initial presentation, optic neuritis. A lot of cases present with that. And of course, spinal cord too. So anywhere there's white matter, so brain, optic nerve, spinal cord, they can all have lesions. And it's the most common of all the demolishing disorders we're going to talk about. Who gets autoimmune diseases? Women, usually in their reproductive age, twice as much common. But of course, men can get it too, but twice much more in women. And it's most common in northern latitudes. What does that mean? Well, my Canadian friends, British Columbia has the highest rate of MS in the world. The more north you go, the higher the risk. If you go to the equator, you go to Ecuador, you don't see this. It's very rare in Ecuador. But you go up to British Columbia, Canada, you see a lot. Now, how could you explain that? Well, some of the theories are in cold climates, you don't see the sun. So this may be a lack of sunlight leading to vitamin D deficiency. Number two, more colds, more viruses. When you're in the colder climate, you get more colds, more viruses. So it could be triggered by a virus. Remember, immune diseases are usually triggered by something in the environment. So could it be vitamin D deficiency with a virus? Smoking probably plays a role too. It doesn't have to, but it may. So it's probably a combination of things. So if I have the right HLA to start with, and then I get a deficiency plus a virus, or smoking plus a deficiency, or smoking with a virus, that triggers an immune response. So again, it might be different. Some people may be vitamin D, some people may be smoking, some people, it might be a combo. This is why there's no one answer, because we're still trying to figure out. It's probably more than one thing. So you get the right HLA, you get the right exposure, now you get an autoimmune response. Now, how do I know it's autoimmune? Because we see oligoclonal. Oligoclonal. What does that mean? Well, not one clone. One clone is monoclonal. That's a tumor. Monoclonal, that's a tumor. Oligoclonal means a couple of clones decided to attack you. For my Star Wars friends, it's like Attack of the Clones. There's a couple of clones who decided to attack you. So there's a couple of CD4 helper 1 type cells, a couple of T helper 17 cells, a couple of T cytotoxic cells, and a couple of B cells, making oligoclonal IgG. So we're going to see bands of IgG, oligoclonal bands, in the CSF. We'll see bands of them because there's a couple of IgGs you're making against your own myelin. So again, oligoclonal means a couple of clones of T cells, a couple of clones of B cells, a couple of IgGs are attacking you. And that's the key. You gotta look for this oligoclonal stuff to confirm this autoimmune nature. Now question, what are they attacking? The myelin. Well, what cell is myelin? Oh yeah, this is an attack of oligodendrocytes. So wait a second, I'm looking for oligoclonal attacking oligodendrocytes? Oligoclonal against oligodendrocytes? Yeah. Now, do you remember what the kissing cousin disease would be in the peripheral nervous system? If our immune system started attacking peripheral myelin, which are Schwann cells, we would call that Guillain-Barré. So Guillain-Barré is like the kissing cousin. So in the peripheral nervous system, Guillain-Barré. In the central nervous system, you attack oligodendrocytes. We call it MS. So that's how we know it's autoimmune. All right, now who has gotten this? Well, I'll just share a couple of famous people, and you're probably too young to know any of these. But there was a talk show host called Montel Williams. He had a talk show, and he once wanted to get a flare. He'd have to stop the taping of the show. You're definitely too young for this. Or the original Mouseketeers, Annette Funicello. My mom cried so much when she got sick. I know. She's like, this is like, you're thinking Britney, you're thinking Christina Aguilera, you're thinking Justin Timberlake. Yeah, that's your Mouseketeers. But yeah, she was on the original Mouseketeers. How about this one? Do you guys remember the comedian Richard Pryor? He was in a lot of movies. Richard Pryor, maybe? No, you're too young. You're the MTV generation. Do you remember on MTV, the Osbournes? Well, his son, Jack Osbourne, diagnosed with MS. His son. So, all right, I finally got one person that you recognize. Yes, MTV. So this is a pretty common disease. Pretty common disease. A lot of people have gotten it. All right, now, since it is autoimmune, it comes and goes. So you get relapses and then remissions, relapses and remissions, relapses and remissions, comes and goes. Now, during the acute attack, you get demyelination. That means you lose nerve conduction. Without myelin, the nerve conduction drops to very slow rates, so it doesn't work. And that's what produces the neurologic deficit. So really the key is, where did it demyelinate? Which tract? That will tell me what symptoms. Okay, so whatever demyelinates, that will give me the symptoms. Now, there will be inflammation because your immune system is coming in. You'll see T cells, B cells, and you'll also see macrophages coming in to eat the dead oligodendrocytes myelin. They're just having a free lunch. Eating it up. So those we call them Gitter cells. They have a lot of myelin inside them. And of course, the axons are still preserved initially. So we lost the myelination, myelin's gone, but the axon's still there. Now that's important, because if the axon is still there, what could I do to get better? I could remyelinate it. I can get better. I can get some of my symptoms to go away by remyelinating it. So that's important. So it's going to take a few weeks, but I'm going to try to remyelinate. So it usually takes a few weeks, but my neurologic function should come back. Now, these are called chronic plaques. The chronic plaque is when the inflammation goes away and your body remyelinates and you get return to some of the function. Now, here's the problem. When you remyelinate, new myelin is thinner. It's not thick like it was when you were born. It's thinner, and the nodes around VA are closer together. So now, instead of jumping from here to here, saltatory jump, 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 now it's got to go jump, 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 jump. It takes longer. It takes longer now. So I'm going to get better, but never 100%. So if I was going to draw this like as a picture, I draw it like this. You start out with perfect function. Then, God forbid, you had an episode where you got demyelination. So now, all of a sudden, you're going to get symptoms, facial droop, weakness, numbness. You suddenly get these neurologic symptoms. And then slowly, over a few weeks, you start remyelinating and your symptoms go away. Now notice, I got mostly better, but not 100%. Then I got another episode. Oh no, I lost function again. And then again, it takes time, takes weeks, maybe a month or so, and I get almost back to normal. But notice this slow downward progression. So each time I get an episode, I'm never quite as good as I was before. And that's the problem, is slowly over time, going down, going down, going down. Or the Carolina, oh no, no, I love hockey. Hockey players, no. All right, now to make this diagnosis, we want clinical history, we want MRIs to see demyelinating plaques, and I want the CSF to look for oligoclonal IgGs. So again, it's like a triad here. We look for the clinical history, we look at the MRI to look for demyelinating plaques, and we do CSF to look for oligoclonal things. Now, here's the key for the history. We're looking for neurologic deficits that are separated in time. So it doesn't happen once and never happens again. It happens, then it gets better, then it happens again, and then each time it's different. If it's the same thing each time, it's ischemia. There's ischemia to that area. But if it's different each time, that means different areas of the brain are involved. So that's the key. Neurologic deficits that are separated over time, and they're separated in the brain in different places. So separated in time, separated in space. Because if it keeps going the same area, that's not MS. It's going to be different each time because different areas belong in. Now, a classic presenting finding is optic neuritis, which means one eye is going to have visual impairment. I'm going to have optic nerve problems. So I'm going to get visual loss, blurring of vision in one eye. And then hopefully it comes back. Now, this is a frequent initial presentation of MS. And then notice, people who have it are very common to go on to develop MS. So it's usually a presenting finding, or you can start just with optic neuritis and then later on develop symptoms in other areas, okay? But again, very common to present with optic neuritis, usually with some motor weakness and sensory loss. That's a classic presenting finding. So optic neuritis with motor weakness and sensory loss. And it could be anywhere, the trunks, the limbs, you can get spasticity, you can have bladder incontinence. If the brain's not involved, you get a cranial nerve findings, the cerebellum ataxia and nystagmus, intranuclear ophthalmoplegia is also very common as well. So these are, here's the key. Any neurologic symptom under the sun can occur because any part of the white matter can demolish. You can even have psychosis. You can have psychosis from this, depending on which part of the white matter. The frontal lobe, you get personality changes. Wow. So again, the key here is to look for different areas of brain involvement at different times. Now, for the CSF, we're going to check the CSF and look for what's called oligoclonal bands of IgG. Now, normally, here's your plasma, here's your CSF. Notice in the CSF, all the IgG should be spread out. I shouldn't really see any bands in this area. Shouldn't see any bands in this area. It should just be all spread out diffuse. Now, if you notice here, it's kind of hard to see. I wish it was a little more distinguished. Here's one band. Here's another band. Here's a third. There's like 3 bands here. And again, I wish it was a little bit more discreet. It's not the best picture I've ever seen. But clearly, it's different than what it's supposed to be, right? It's supposed to look like this. And now it looks like this. And again, these are bands. They're very faint in terms of the distinguish between them. But here's one band. Here's the line for the next band. It's like 3 bands, it looks like, too. So you got 3 different IgGs attacking your myelin. So that's the key here. Now, on the spinal tap, the protein is increased because the inflammation and all the myelin protein breakdown. The IgG levels increased, and you're going to see oligoclonal bands. So in other words, a couple of clones. It's not one clone. If I just saw one band like this, just one band, that would be myeloma. That's myeloma involving the brain. But this is multiple bands in here. And again, this suggests that it's activated clones and try to attack myself. That's what you see oligoclonal. You've got to think about the immune system. All right, now here's what it actually looks like. Do you remember gray matter is gray? Because there's no myelin, right? That's why it's gray. White matter is white because of myelination, right? So these things here are not the eyes of the brain. I know it looks like eyes, they're not the eyes. These are called lateral ventricles. Well, above them should be white matter. These should be the radiating fibers of the centrum semia valley, right? These are the radiating fibers that are going to go out to the gray matter peripherally, right? These are the radiating fibers. Well, this should all be white matter. It should all be white. So please tell me, I'll outline it for you. What is this thing right there? Looks like gray matter. Exactly. That's not normal. That's an MS plaque. Now on the other side, it's even more obvious. Look at the size of this area here. This is why this patient's dead, by the way. If you see this much demyelination, you're not going to live. That's a lot of neurologic loss. So they put a P for plaque. This is the large MS plaque, and it basically killed the patient. Now, this picture is easy because number 1, it says MS. And number 2, your eyes see asymmetry. When something's asymmetrical, your eye sees it. It immediately looks for something that's different. It sees it. This picture's easy. Students say, John, I was on the exam, and they give me all these neurologic problems, motor and sensory, these like so many, then they show me the brain. And I took one look and I was like, I don't see hemorrhage, I don't see a mass, I don't see a tumor, what's up? Then he remembered what I told him. MS plaques are usually next to the ventricles. So look at the ventricle, above the ventricle should be white. If it's gray, that's not normal, because his picture looked like this. Let me draw it. They made it symmetrical. They found an example that was totally symmetrical. So the plaque on this side looked exactly like the plaque on this side. I mean, it looked exactly the same. So his eyes didn't see it. His eyes, he took a look at the brain, everything looked good. He was like, I don't know what's wrong. And then he said, Barone said, if you don't see anything wrong and there's a lot of neurologic history, look at the eyes and look above it. Now question, if these are eyes, what would these represent? Those would represent eyebrows. So if the eyes have eyebrows, that's MS. Shouldn't be eyebrows on your eyes and brain. So these are like eyebrows. And again, this picture is easy because it's asymmetrical. If I make it symmetric, trust me, students will miss it. They'll miss it. Now to see these, we don't want to do an autopsy. We want to see them, and you see them really well with MRI. So MRI is really good for lighting them up, and they're usually right next to the ventricles. So look next to the ventricles on MRI, and they'll light them right up. So here's, I'm going to show you the gross first, and I'll show you the MRI. Here's another example. Notice the demyelinating area next to the ventricle. Again, this is a very big plaque. This patient's going to have severe symptoms. And then here's an MS plaque. This is a myelin stain, by the way. They call it a Luxol fast blue periodic acid shift stain. We're using this to light up the myelin. So everything that's blue is nice and myelinated. Myelinated, 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 demyelinated. That's an MS plaque. Here's another MS plaque. Here's another MS plaque. This is the fourth ventricle, by the way. So there's four MS plaques are on the fourth ventricle in this place. It's usually next to these ventricles. So look next to ventricles. That's where you see all these plaques. Although this one isn't. This one's not the right location. But MS plaques are usually next to the ventricles, but they could be anywhere. They could be in the spinal cord too. Could be anywhere. Now to see them, we like the MRI. So if we look at this MRI, we have two types. We have MRI T1 weighted and T2 weighted. T1, it's going to look hypo-intense. It's going to look dark. But in T2, it looks really bright. Really easy to see on a T2 weighted stain. You see it really well. Now, do you guys remember Terminator? In Terminator 1, he was bad. In Terminator 2, come with me if you want to live. So the T2, you can really see it lights up on the T2. You can see he's good, you can see it good. So you can see it good there. Notice it next to the ventricle. Beautiful. All right, perfect place to take a break. When we come back, we'll do our last 40 minutes and we'll be out of here. All right, I'll see you guys in a few minutes.
We're gonna tussle. I can already tell. This transition is gonna be
super excited about it. I was gonna tackle him and oh wait, is this on recording?
Yeah.
I shouldn't say what I was gonna do. Slam. What's happening?
Oh my gosh.
This was
Not
a bad
sure.
move. This was a very bad move on you. I don't know why you thought the floor would be better. Oh, whoops. Oh.
Probably.
Hey.
I'm allergic to my new soap. Now I have a rash on my hand.
It's a rash.
Yeah, and then this iWatch band. Also, I'm getting a rash. Look at everything.
Just don't shower.
It was Bath and Body Works, like those little like pumpy ones, and I've had multiple flavors.
Why
I've never had a problem before. But I
What?
switched 2 days ago to a new flavor.
What? Look at that. The
It's
first
something
one.
really stupid, like
Why is he there?
pumpkin latte or something terrible. I know.
Doesn't seem right.
I know. I don't know. Maybe it's not.
Why is this
Might
up
be
here?
watch it.
I don't know.
Really?
Gives me like
You gonna help me with that?
a rash.
Yeah. See, this was doing it. It's guys
That
with that
challenge?
other band, and then now that
Huh?
other band
That
is like
challenge?
all
You're actually
apart,
gonna do
so
it?
it's
Yeah.
Not take it.
fun, but not-
Hopefully that worked.
That would have busted open. That would have been
I
tragic.
know.
If I
I would.
the wall, that was bad too.
50% of me was like, I don't give a shit. 50% was I still need to clean up after that. It gets on
So one of those dessert cups that I stole was in fact tiramisu, but sadly I found out because it was on the floor.
I was gonna say, you're not gonna give it to me.
Yeah, I was. If it was tiramisu, I went to investigate and I dropped it on the floor and my cat played it. So, so you missed out. But pumpkin and mental got to benefit.
Interesting.
Yeah.
Wow. Or is it just dogs that die from chocolate?
I don't know.
I don't know, dude.
They have eaten a lot of food they should eat earlier. So
Yeah. My dogs have eaten a lot of stuff that they're not allowed to eat and it's fine.
My dog grew up growing up, ate fudgesicles all the time. And it was never about
It's mostly like pure cocoa that's like bad for them.
Oh.
So like all like the chocolate things aren't that bad. It's more just like, you know what I mean?
Yeah.
It's not real chocolate.
That's because one time my dog ate an entire pack of Oreos, like one of those big Oreo packages, and she was fine. But like, you know, it's real chocolate. Is really
Yeah.
Oreo.
Like milk chocolate isn't as bad.
Yeah.
I remember my roommate's dog senior year like ate a whole bag of Reese's, and like they already rebagged. It's like the bag with the wrapped Reese's, like so like he ate all the plastic too.
No.
And it's just like I think that maybe saved him, like his like they're all just wrappers, so they never absorbed any chocolate or something.
Oh my gosh. Maybe that's a myth. Maybe they really don't die. Or
Also, my other roommate was such a jerk. The dog was never getting into stuff. Like the dog was fine, but then my other roommate brought his dog every once in a while from home, and every time that dog would come home, or he'd bring that dog, we'd come back from class, it should be everywhere torn up, and he's like, my dog would never do that. And he blamed it on the resident dog, and I'm like, you're an idiot. It's only your dog that it happens when your dog's here. Like,
Oh my god.
he wouldn't believe it. He was so mad. He'd like yell at the dog that didn't do it.
Oh,
Oh my god, it was horrible.
that's sad.
It was sad. Are you gonna do anything with that picture?
No, I'm just gonna leave him brought up.
Hello? I think you should link it to
On here. Look at this. Look at this picture of me.
Last night, Liam sent me a video. He apparently has another stray cat that's now.
a stray cat in Fort Wayne. I mean, in Terre Haute.
Where are we?
It is
Yeah,
sometimes.
yeah, I know. I was like, I think he might be a crazy cat lady.
Who has a stray cat?
Liam.
Liam's been like trying to like
He's
take
collecting
it.
cats?
Yeah,
Yeah, I think I converted him.
he like puts out food for them and everything, and like you know, there's an abundance of those things in Terre Haute everywhere. I almost hit one driving middle of the day coming here the other day, like just by the hospital, just like on this side of the hospital.
Did you
like,
say
middle of traffic?
wrong because he didn't hit it?
That is, you got me. You
Oh.
got me.
Wait, 12 is an hour. I'll get one back. I need to fill my water bottle too, because it's getting a little low. I'm also gonna drink some of my water bottle because I'm getting a little low
There you go.
of water.
It's not drinking yet. Hey, look at Kevin.
Let's see. That's pretty good.
Oh yeah, what a good day. A good day of program. Okay, the tape is rolling. It's rolling, and so are we. We're talking about a very important group of diseases called demyelinating diseases. MS is by far the most tested. You're going to see it. You're going to know people have it. It is a devastating disease. I don't wish it on anyone. So we got to make sure we figure out what this immune system is all about and make sure we can reverse it. So how do we treat most autoimmune diseases? Well, steroids and immunosuppressive drugs. So I want to bring two to your attention. The first one is interferon beta. Interferon beta. Why? Because it is a one disease drug. It's a one disease drug. Interferon alpha, we use it for lots of diseases. Interferon gamma, lots of diseases. Interferon beta, only one disease that we use it for. So on an exam question, you see interferon beta, you're dealing with MS. Only time you ever use it. And the other question I want to bring up is for refractory cases. The initial steroids and the suppression doesn't work. USMLE will ask you in MS, what drug would prevent the migration of lymphocytes into the CNS? Remember, it's the lymphocytes coming in, the B and T cells, that are going to create antibodies and damage the oligodendrocytes. So we can stop lymphocytes from coming in, we can stop a lot of the damage. So do you remember to attach to the wall and then emigrate through the wall? You need adhesion molecules, the important one with the integrins. So we've made a monoclonal antibody against the integrins. It is called natalizumab. Love the name. Anytime there's a mab, I know it's a monoclonal antibody. Now, it's an antibody against the lymphocyte adhesion molecule called interleukins. So again, it's a monoclonal antibody against the adhesion molecule integrins, interleukins, the integrin. So it knocks out the integrins. Now your lymphocytes are paralyzed. They can't bind to the wall. They can't emigrate into the brain. They can't cause damage. And this has been approved not just for refractory cases of MS, again, not first line, but refractory cases, but it's also approved for refractory Crohn's disease as well. This is great stuff. So again, not first line, but you can use this for recurrent or refractory cases. Now, the reason they made a big deal about this is it sounded like a great idea, right? Let's make antibodies against these little adhesion molecules called integrins, and then we'll stop the cells from binding. The integrins don't work, cells can't stick, they can't come in, right? Great idea, except it really knocks out your immune system good. In fact, it basically wipes out the immune system. So now you're at risk for reactivation of the JC virus. Yeah, it's weird. We've almost all been infected with JC and CMV. Almost all of us are positive for it. But the good news is, as long as we're immune competent, we'll never have a problem from it. We'll never have a problem. But if our CD4 count drops down, the JC virus can come out, and it's going to cause progressive multifocal leukoencephalopathy. Now, progressive means it's going to kill you because there's no immune system to stop the virus. Multifocal, that's obvious. Multifocal leuko. Leuko, that's white matter. So multiple plaques of demyelination. Wait, this is going to look exactly like MS. Yup, it looks exactly like MS, except multiple sclerosis comes and goes and comes and goes. This comes one time and it kills you because you have no immune system. It's going to progress and kill you. is very bad. So here's what happened. They put them on this drug. They said, let's try it. There's a refractory case, let's try it. The MS got better. Here's another case. Let's try natalizumab. Try it. It got better. Here's another refractory MS case. Let's try natalizumab. It got better. Here's another case. Let's try natalizumab. The MS got worse and they died. And they're like, what happened? Everybody got better but them. They got worse and died. Stop it. Nope. They took it off the market. They took natalizumab off the market until they figured out what happened. They thought the MS got worse. No. They gave too much natalizumab. It knocked the immune system out. So your CD4 count was basically less than 50, basically, because the cells don't work. It's like having a CD4 count less than 50. And now the JC virus came out. They got PML, which looked like MS. So the MS actually got better. It's the JC virus that came out. They got PML, which looked like MS. So once they did the autopsy, they saw it was the JC virus, and they said, okay, we're putting it back on the market, but with a big label, a big warning saying, you can give natalizumab for refractory cases, but don't give too much. If you give too much, there's a risk of PML because of the JC virus reactivation. Now, if in real life they took it off the market for that reason and then they put it back on when they figured it out, don't you think the board's going to ask that? That the risk of natalizumab is the JC virus? You know they're going to ask that. That's like pretty much a giveaway. So here's how to remember this drug. Natalizumab is a monoclonal antibody against integrins. So Natalia, hot Russian. All Natalias and Natashas are hot. Think of the Avengers. Natashas, Natalias, they're all hot. So imagine, gentlemen, a hot Russian, Natalia, wants to leave you and emigrate to America, to the brain. She wants to leave you and go to the brain? What are you going to say, gentlemen? Niet, niet, natalizumab. Now you paralyze her and she can't leave. Yeah, I tried doing that at the bar. Girl wants to walk away. The polarizing agents, she gets paralyzed and I just carry her away. No, I don't do that. You get arrested. But this is a great paralyzer for for lymphocytes. Works really, really good for lymphocytes. So again, that's how I remember. Natalizumab, hot Russian wants to leave you and go to the brain. Niet. Natalizumab will paralyze her and don't let her leave. All right. Now let's talk a little bit more about PML. PML, and I always remember as PML is pray to my Lord Jesus Christ. Remember, this is not Jakob Creutzfeldt. That's a favorite trap. Jakob Creutzfeldt was a prion protein. This is a polyoma virus. So JC are the initials of the first person they found the virus in. His name was John Cunningham. You don't have to know his name, just know his name was not Jakob Creutzfeldt. So it's not Jakob Creutzfeldt. So I just call it pray to my Lord Jesus Christ, so that I don't think it's Jakob Creutzfeldt. Now, when this virus reactivates because of immune suppression, you'll get patchy multifocal demyelinating plaques. Do you see this patchy? Again, this is a Luxel blue PAS stains. You can see the myelin is blue, and these pinker areas are areas of demyelination. You see how patchy it is? Man, oh man, that's a lot of demyelination. A lot of demyelination here. All right, now it's usually going to affect the oligodendrocytes. That's what it's tropism for. And you'll see intranuclear inclusions. If you look really closely, you'll see inclusions in the nucleus because this is a DNA polyoma virus. So again, it affects oligodendrocytes. So look at these pictures. Here are these big old cells here with big nuclei. These are the oligodendrocytes that have been infected by the virus. So you can see inclusions. That's what this purple thing is here. These are the intranuclear inclusions. Intranuclear inclusions. All right, now who's going to get this? Well, your CD4 count literally has to be less than 50. For this virus to come back, CD4 has to be less than 50. So we're going to see this usually in AIDS patients, or people on natalizumab, or somebody with a bone marrow transplant. Somebody severely immunosuppressed, that's when you see it. And again, it usually progresses to death by 6 months unless you can reverse the immunosuppression. Get the immune system back. Otherwise, 6 months, they're gone. That's why I call it progressive. Not a good disease to have. And very testable. They like to test it. They try to confuse students with the JC virus and Yakov-Creutzfeldt prion protein. They try to confuse you. Great. Now, this one is fascinating. Central pontine myelinolysis. So basically, your myelin is lysing in the basis pontus, the center of the pons. That's called the basis pontus. Now, this is an acute demyelin disorder, and it's caused whenever you try to rapidly correct hyponatremia. So if somebody's been living with it. So you've been homeless, you've been living with low sodium, and then the medical student comes in and says, oh, the sodium's really low. Let's give you a big bolus of saline. Well, if you rapidly correct it, you basically shift fluid and you demyelinate your basis pontus, and that will kill you. So this is most common in people who are malnourished and homeless. So alcoholics, people that are not eating right, so severely malnourished people or people that are alcoholics. These are the people who can have electrolyte imbalances and have hypernatremia like this. Now, unfortunately, this is going to be an osmotic demyelination of the basis pontus, and that is going to give you rapid quadriplegia. And there's not much you can do once you've done it. So once you give that bolus and you're like, oops, I should always correct sodium slowly. Oh, too late, too late. There's actually a protocol when sodium is really low of how fast to correct it. But the key is you want to correct it slowly over days. You don't want to give one or two rapid boluses. Now, if you take a look at the pons, do you see the basis pontus right here? Boom, it is literally demyelinated. It's all demyelinated, it's all lighting up there. So you got an MRI of the pons, and there you see it, and that's going to explain why this poor dude, this alcoholic who came in and was fine, is now suddenly a quadriplegic. Horrible thing to do. Can you get this from secreting antidiuretic? Well, remember, the syndrome of inappropriate ADH is about water. So the sodium is going to appear to be really high. Well, let's see, in the syndrome of inappropriate ADH, you make too much antidiuretic, so you hold on to a lot of fluid. So therefore, the sodium appears low, but it's really diluted. It's really been diluted. So it's more the water than the sodium that's the issue. And it's also slow. It's not rapid. It's slow, right? But if you reverse it, try to reverse it quickly, anytime you reverse something that you've been living with, you can get it. So Kevin is right. If you rapidly try to correct their sodium, you'd have the same problem. So again, we don't want to correct sodium quickly by giving boluses. Again, how do you treat the syndrome of inappropriate ADH secretion? Do you remember how you treat it? Get too much water? Yeah, Vaptans. Get rid of the water. Don't just the sodium, the water. Very good. Very good. But if you did give them a big bolus of saline, that would not be a good thing to do. Very good, Kevin. Nice integration. Love it. All right, so again, not common, but it is a cause of lawsuits. All right, now our fourth problem with myelin is the leukodystrophy. Leuko is white, dys is abnormal growth. So it's basically a problem making myelin or maintaining myelin or breaking down and regenerating the myelin. It's something about the body's ability to make the myelin. So this is a group of inherited, unfortunately progressive, dysmyelinating, not demyelinating, dysmyelinating. You're not making myelin properly, or you can't break it down, you can't maintain it. That's the problem here. And these are usually going to be young. They're going to present young because these are genetic, and most of them are going to be recessive. Not all, but most of them are going to be recessive, and it's going to present very young. So young people. MS is usually adults in their reproductive age. So this is going to be much younger. Now, obviously, when the central myelin is affected, you're going to have odor, and spasticity, ataxia. When the peripheral myelin is affected, now you're going to get weakness and hypotonia, loss of reflexes. So, again, the big difference between upper motor and lower motor neuron findings. Okay, now here's a couple that have been tested. This one's fascinating. Metachromatic, different color, leukodystrophy. This is the most common of the leukodystrophies. Now, it's a recessive deficiency of a lysosomal. Oh, so is this a lysosomal problem? Got it. And the enzyme is called aryl sulfatase A. Aryl sulfatase A. So always remember Aryl. Aryl. Ariel sulfatase. Ariel. Do you remember the Little Mermaid? Ariel? And remember, she had red hair and she had blue fins. She had different colors. Under the sea, under the sea. You'll see all different colors under the sea. Yeah, you'll see all different colors. So you're going to accumulate sulfatides inside the lysosomes, lysosomal storage problem, and they're going to stain with different colors when you use a crystal violet or a toluene blue stain. You get all these different colors. So very colorful, like Ariel and Under the Sea, all those beautiful sea colors, right? Now, somebody was telling me, how about Ariana Stark? Ariana Stark, didn't Ariana, no, is it Ariana? Which is the one that's being trained by the face? You take the face off. Is it Ariana? Arya Stark. Okay, Arya Stark. Thank you. Arya's not Ariana Grande. Hey, we're working on mnemonics here. Ring chains, good. But Arya, and isn't she suffering with the face, taking the face off? She's suffering with the man with no face, and they try to kill her and everything. So Ariel is suffering with the man in the face, and the movie's very colorful. I don't know if I get the color in there. Shucks. I don't know. All right, so that one didn't work. he's like Ariel Stark suffered with the man with the face with no face, and I'm like, okay, great. But then how do I link it up to the different colors that it's metachromatic leukodystrophy? All right, we got to work on the connection. I love it. Students give me ideas. I just have to work on them. All right, now the next one is Krabbe disease. Krabby Patty. Give me a Krabby Patty. Got money? You got money? I'll give you a Krabby Patty. Do you remember Mr. Krabs? Isn't Mr. Krabs kind of globular? Isn't his body kind of globular, Mr. Krabs? He looks like a big globe, right? Big globus? Yeah, that's important. This is a recessive deficiency of galactocerebroside beta-galactosidase. Galacto. Money, galacto. He's always repeating money, right? He's always about money. He's out of this galaxy, wants money. And he's globular. He's like round. He's like a globe. So you're going to see these globoid cells. And again, this is because you're going to accumulate undigested. Without this enzyme, you can't digest galactocerebroside. So it's going to accumulate and engorge the macrophages, and they're big and round like Mr. Krabs. Give me a Krabby Patty. So again, that's one of the diagnostic features, globoid cells. So Krabby and globoid, round like Mr. Krabs. And again, he said, we want money, galacto. I gotta get something better. Black. Then they go, black. No, I'm the only one who watches SpongeBob. Never mind. I tried. All right, now this is the one where they make movies about it. Adrenoleukodystrophy. So abnormal growth of the white matter and the adrenal. So that's the key here. Not only do you get the neurologic, right? Both of these are white matter demyelination. This is white matter demyelination, but it also has adrenal insufficiency. It has Addison's. That's what makes this one quite unique. Addison's plus a white matter problem with myelin. Now this is X-linked, so it's only going to be boys here. It's only going to be boys. And it's a problem with the transporter, the peroxisomal transporter, so they have trouble transporting and breaking down very long chain fatty acids. So they can't really transport them in and do beta peroxidation. They can't break them down. So these are going to basically accumulate because you can't transport them in and break them down. So they accumulate in the brain, and that's what causes the demyelination. And the adrenal, that's what causes the adrenal to become insufficient. So it's going to have atrophy and insufficiency, basically Addison's disease. And this is the one where they made the movie Lorenzo's Oil. Yeah, because their son was born with this terrible disease. The adrenal, do you remember you get bronze, you get darker, your cortisol drops, you have trouble with the blood pressure, you have all these, you're missing the sex, salt, and sugar, right? Sex, salt, and sugar, Addison's. And also you're going to have all these neurologic problems, which are terrible. So they were watching their son suffer. And they're like, well, we're scientists. We got to figure out a way to help our kid. So basically, they started doing research and they developed this oil that can help stop this accumulation. So isn't that great? I mean, that's motivation. Like your kid is dying, they're highly motivated to try to figure it out. And they figured it out, right? If you're working for money, that's one thing. You're working to save somebody's life, that's a whole different level of motivation. So they were able to figure it out. Now, what's interesting is it's controversial whether it works very well. I think it works best if you give it before the symptoms. Once this demyelination, hard to grow it back. But I think that's the problem why it's so controversial. They were giving it to people who already had symptoms, so it's going to slow it down, but it's not really going to make you better. If you give it before they have symptoms, I think that's when it's most effective. But again, it is controversial. If you go to the FDA, they call it experimental still, but it's a pretty darn interesting movie. If you watch the movie, it's kind of an older movie with Nick Nolte, Susan Sarandon. It's kind of an older movie, but it was quite a good movie. So if you get a chance to watch it, it's about adrenoleukodystrophy. All right, last one is Alexander's disease. I don't hear it asked that much. What they'll probably ask you is it's a recessive, so it's going to be very early. It's a problem with GFAP. This is what's mutated, and it's now going to accumulate in the astrocytes. So your astrocytes are going to have these accumulations, and they're going to create Rosenthal fibers. So that's kind of important. It's kind of different. This is affecting the white matter and the astrocytes too. So different. It's got astrocyte involvement. That's kind of cool. Rosenthal fibers. Again, when I hear Rosenthal fibers, I think of a tumor. I think of pilocytic astrocytomas first. Always think about them first. All right, pretty good. So demyelinating diseases are done. Now we got another category. And this category is also high yield. Man, this whole chapter is high yield. Yep, I told you, we saved the best to the end. All this stuff is super, super high yield. Look at this: Alzheimer's disease, Pick's disease, Lewy body dementia, Parkinson, Huntington, Friedreich's ataxia, ALS. I mean, wow, this is like a who's who of high yield. So what do they have in common? Well, obviously, neurons are going to degenerate. Neurons are going to die, right? And when neurons die, let's see, my neurons do my thinking, so you're going to get dementia. You're going to have trouble with your higher intellectual functions, because you're losing neurons. Now, obviously, it depends on which neurons you're losing. That will determine which. Is it motor neurons? Because you're going to get muscle problems. So it really depends on which neurons are dying. But here's what you should know. Okay, the first three are going to affect the cortical neurons mostly. So again, it's higher cognitive functions, thinking, memory, thoughts, personality. That's what's going to be affected. Okay, cortical problems. And that's going to lead to dementia, obviously. Forgetfulness. All right, now Parkinson's and Huntington's affect basal ganglia. Let's see, what was basal ganglia part for? Movement. So you're going to get movement problems, either too much movement, curiform, or you can't move. You're kind of trapped. You're getting cogwheel rigidity and shuffling gaits, and you're basically trapped, can't move very much. So this is going to be about movement problems. Now, Friedreich's ataxia is about the cerebellum and spinal cord. So this is a spinocerebellar disorder. So obviously, when you have cerebellar problems, you're going to have trouble with balance. So ataxia, big issue there. They'll be in wheelchairs by age 5. And then, of course, Lou Gehrig's disease is a motor neuron. No sensory here whatsoever. If there's any sensory, it ain't Lou Gehrig's. This is pure motor. So this is going to give you muscle weakness, muscle atrophy. This is about the muscles not working because there's no stimulation. The muscle's like, stimulate me, stimulate me, stimulate me. They start twitching, they start atrophying, and they basically degenerate. That's the problem. Denervation, atrophy is what you'll see. All right, so it's the big picture. Now, the problem with these diseases, and these are the general rules here, the problem is neurons are going to degenerate. Neurons are going to get lost. That's why it's a neurodegenerative disease, and that leads to pathology. Now, one of the reasons that they're going to break down is because proteins are clogging them up. So you're going to see classic proteins accumulate. So neurons degenerate, proteins accumulate, neurons degenerate, proteins accumulate. We can make a rap song here. So neurons degenerate and proteins accumulate. So what do you think the board may ask you? What protein? What do they look like? What kind of bodies do they make? And then what are they made of? What proteins it specifically? They love it. So some people call these proteinopathies. Proteinopathies because proteins accumulate. So here's a nice list for you. We'll see them again, but you gotta get these bodies in your brain. Yeah, that's a double entendre. Bodies in the brain, get these bodies knowledge in your brain. Okay, don't get these actually in your brain, but get the knowledge in your brain. Yes. So you're going to see Alzheimer's having amyloid, beta amyloid. We'll also see tau, but tau is not just in Alzheimer's, it's in frontotemporal lobular degeneration. It'll be in other things too. It's a group of disease called tauopathies. What else? Alpha-synuclein. Alpha-synuclein accumulates as Lewy bodies. So you'll see it in Parkinson's and Lewy body dementia, because it's the major component of Lewy bodies. What else? TAR DNA binding protein 43. This accumulates in Lou Gehrig's disease and frontal temporal lobular degeneration. SOD1. These mutations are often found in ALS, and they tend to accumulate and clog up the cell. So they may literally be causing the unfolded protein response. That may be one of the reasons the motor neurons are dying and getting apoptosis. What else? Huntington. Huntington's going to have Huntington protein accumulate, and it's toxic. It's really long. It's got a triplet repeat, which makes it toxic, and it kills the cells. And of course, ataxin. Maybe that accumulates in Friedreich's ataxia, a protein called ataxin. So again, proteinopathies. Now, why are the proteins accumulating? Well, sometimes it's a problem with ubiquitization. You're having these abnormal proteins, you got to ubiquitize them. If you can't get rid of them quick enough, they can accumulate. So often there are problems with the ubiquitin proteasome pathway. In fact, one of the things we're working on is ways to increase the breakdown of these proteins. We're trying to say, if we can get rid of these, maybe they'll get better. That would be so cool. So we're working on ways to improve ubiquitization and proteasome function. Try to break some of this junk down, because accumulation of the junk crowds out other things. You've seen hoarders, right? When they hoard, the house is full of junk. You can't even get to the house. There's too much junk in the way. Same thing for your brain. Your neurons can't function properly while there's junk accumulates. And then finally, a common cause of death. And this is universal. Whatever makes you bedridden. Who is the old man's friend? Bronchopneumonia. You wind up aspirating, and it's the old man's friend, bronchopneumonia, that usually ends your life. So that's just common for all these. Pretty much bronchopneumonia is usually what pushes them over the edge. Very sad. All right, and by the way, you can do a lot of good here, because the brain is the great unknown. We don't really understand. It's like the deep ocean. We haven't really been to the really deep ocean. We don't even know what's there. And we don't really know what's in the brain. It's a mystery. It's a mystery. So why not you? Great discoveries are made by young students. You're fresh. You haven't been beaten down. Do it my way, do it my way, do it my way, do it my way. Oh, in the next couple of years, that's what you're going to be trained to do. Do it my way. You'll see. When you're in the fourth year, they'll start saying, do it this way. Then you're a resident, do it my way. And then you're an attending, well, now I've been trained to do it that way, I'm going to keep doing it that way. So they don't think as much. You're fresh. You're asking why? Why don't you do that? Why don't you do it? The attending's like, well, because it works. We've always done it that way. And you're like, why? And really great discoveries are often made like this. You see them doing something in one field, then you go to another rotation and you say, hey, why don't you do that here? And great discoveries are made because you start doing, well, let's do it over there. Great discoveries. Why not you? And that's the way to get rich and famous. If you can figure out a way just to slow this, you don't have to reverse it, just slow it. If you can slow it down, you'll make billions of dollars. You'll be Times Person of the Year. You'll be a billionaire by helping people. Because who's devastated by Alzheimer's, Lou Gehrig's disease, Parkinson's, Huntington's? Who's devastated? Not just the patient. I mean, it's horrible for the patient. The family too. They got to watch their loved one suffer with these nerve diseases, and they can't do anything. You can't really do anything to help. It is a very frustrating. It is, it's devastating for the entire family. People have to take off work. They have to use up their whole savings to pay for stuff. It is just a terrible thing. So again, these are very common diseases. You're going to see Alzheimer's, and you're going to need to know about it. And hopefully you guys will make the great discoveries here, because there's nothing really for these. There's nothing really for them right now. All right, so let's just do one, and then we'll end for the day. Alzheimer's. You're going to do one of the most important. This accounts for 60% of all dementia. 60, wow. So most cases of dementia in older people, usually over 65, that's usually when we see them, is going to be due to Alzheimer's. Now, the second most common, number 2 most common, is going to be multi-infarct, also known as vascular dementia, from multiple infarctions. Okay, so I always like to know most common and also second most common in case they ask. So Alzheimer's is number 1, vascular is number 2, and that's associated with atherosclerosis risk factors and hypertension. All right, now what is dementia? Well, it's progressive loss of your cognitive abilities independent of the state of attention. So it's not like you're comatose, you're awake, but your cognitive function not working. It's not normal aging. Normally, we should not get dementia. We should still be using our brains. We should maybe a little slower, but we should still be okay as we get older. So this is a pathological process. You should not get dementia as you get older. Now, it's the most common cause of dementia in the elderly, and the prevalence is 1% of the population has it between 60 and 64. 1%. And the incidence doubles every 5 years. Every 5 years. Wow. So the biggest risk factor, and that's one of the things they're asking on the exam now. They're asking risk factors because you know all the buzzwords. So that's what is the biggest risk factor? Aging. The older you are, the more likely you are to get this. Now, 5 to 10% are genetic. They run in families, and they're usually autosomal dominant. So that means you're going to pass it on to half your kids. They're going to get it early onset. So they're going to get it in the 50s, early 60s. They get it really early. So that's very bad in the genetic forms. Now, what's protective? Well, use it or lose it. Right now, you're preventing Alzheimer's because you're using your brain. Yeah, you're making your ACH get released. Anything that releases neurotransmitters, you get neuroconduction. I use it. I make those circuits stronger, right? Now, what else is protective? Smoking. Oh, great. Wait till the tobacco companies find out. Oh, great. No, it's not. Can you imagine? I remember I died of lung cancer. Yeah, that's how smoking protects you. It kills you. So you don't make it to 65, you don't get Alzheimer's. Thank you very little, tobacco company. Yeah, smokers don't live long enough. So it's not the smoking, it's the nicotine. Nicotine, also caffeine. Nicotine and caffeine. Why? Because they'll falsely stimulate. They'll increase ACH as well, right? Yeah, they falsely stimulate you. Nicotine and caffeine. Wow. So wait a second. If my patient's developing early Alzheimer's, should I tell them to start smoking? Well, Dr. House does, but you shouldn't. You should. How about, should I tell them to take nicotine and a lot of caffeine? Should I give them a nicotine patch? So you want them to falsely stimulate their brain? Shouldn't you tell them turn off the Kardashians, pick up a book, do some Sudoku? So the preferred recommendation is for them to actively use their brain, do puzzles, do crosswords, use your brain, turn off the boob tube. But I guess nicotine in the studies does seem to be protective, but it's not something we want to recommend because then they'll be up all night. And they won't be up all night to get lucky. They'll be up all night because you gave them nicotine and caffeine. And then they'll have a whole nother set of problems. All right, now classical features. This is the higher intellectual function that's affected, especially memory. So insidious onset of memory impairment for recent stuff. What you did 40 years ago, that's still in there. But what you did last week, you can't remember. It's the recent stuff. It's the new memories that are trouble. They also get alterations in mood and behavior. Wouldn't your mood change if you keep forgetting everything? Wouldn't you change behavior, start leaving your keys in the same spot? I started to do that because I lose my keys every day. Do you remember that one time, though, when you came home at night and you go to sleep and you wake up the next morning, you have to go to work or school or something, and you're like, oh man, I gotta leave, but I can't find my keys. Where did I put them last night? I came in so late, I don't remember. And you're like, I just gotta leave. I'm gonna leave the door open, I hope nobody robs me. I just gotta leave. So you open the door and the keys are in the front door. Do you remember when that happened? Oh, it never happened to you. But imagine that happened every day. I mean, if you can't find your keys every day, and your shoes, and your glasses, every day you can't find them, man, I'm gonna get depressed because I know I'm forgetting. And I'm gonna change my behavior. Makes sense. I'm gonna try to do things to help me remember. Get my pill box with the Monday, Tuesday, Wednesday, write stuff down. You need some help here. Now, unfortunately, they start getting disoriented. They don't remember where they live. You start finding them wandering in the neighborhoods, like in the old neighborhoods. It's like they recognize the neighborhood, but they don't remember where their new house is. And eventually they become mute, immobile, and bedridden. So what is the most common cause of death, which has been asked? Pneumonia. Bronchopneumonia. They aspirate, and that's what kills them. And it usually takes 5, 10, 15 years to run its course. Problem is, there's not much you can do. Not much you can do for this. That's why we need to figure out a way to do something about it. Okay, now genetics. There's lots of genes that can ask here. Now, do you remember the amyloid plaques? Well, they have a core made of amyloid precursor protein. Amyloid precursor, when it gets beta cleavage, that's the bad one, beta cleavage. So we're going to call this BAT protein. Now, the gene that encodes for this is on chromosome 21. So who has an extra copy? Downs. They basically have 3 copies of this gene. So the risk of them getting beta cleavage is really high now because they have an extra copy. So the more beta cleavage, the more amyloid plaques. So they're going to get early onset. So Down's patients get Alzheimer's starting in the 40s and 50s. So that's really early. And that's the reason they have an extra dose of this protein, which is going to make amyloid. Now, for the autosomal dominant genetic ones, presenilin genes are the common ones. Presenilin 1, presenilin 2. With a name like presenilin, do you think it's going to be early, maybe in the 50s? Yep. So when this is mutated, the majority of patients of this autosomal dominant disease are going to get early onset. So autosomal dominant mutation, early onset Alzheimer's. Now these are important because they're part of the thing that cleaves the amyloid precursor protein. They're part of the gamma secretase complex we'll see in a minute. They're important for cleaving the amyloid precursor protein, and therefore can lead to more cleavage of beta pleated sheets. All right, so this gain of function, you have more production of these beta pleated sheets, this amyloid made of beta, that protein. Now what I would test, because everyone should know this one because of Downs. Everyone should know this one, presenilin, early onset, it's dominant, give it to half your kids. But I would ask this one. This is called a susceptibility gene. It increases your risk. It doesn't actually cause it, but it increases your risk. It is the apolipoprotein E gene. Now there's 3 alleles, but the 2 that are important are the E4 allele, and that's very important because it's overrepresented in people with Alzheimer's. So it increases your risk. If you have this E4 allele, you have a higher risk of late onset Alzheimer's. So not early onset, later onset, so after 65. So increased risk for E4. Now E2 is underrepresented in Alzheimer's patients, and therefore it's probably protected. Now, what drives me crazy is this is lipid. Shouldn't this be for atherosclerosis? Yeah. So again, we don't know why, but this is a pretty interesting theory. These may be important for atherosclerosis, and therefore Alzheimer's, because the E4 allele patients tend to have more coronary artery disease. They have more atherosclerosis. Well, guess what? If your coronary arteries are narrow, now your cerebral vessels are narrow too. So less blood flow to your brain, now you can't clean it out. If you don't get blood flow to clean it out, get fresh oxygen and stuff to clean it out, junk is gonna accumulate. So that could explain it. E4 allele patients have more atherosclerosis, so less blood flow to the brain. E2 patients have less atherosclerosis, so more blood flow to the brain. And what may also correspond with this is people who exercise have less Alzheimer's. Probably because they're having more cerebral circulation, better blood flow to their brain. People who are sedentary, less likely. people are said they're less likely to have protection. They're more likely to have to develop this disease. So I think this is interesting. Again, it's only a theory. It's not been proven. Will not be tested. But what you do need to know for sure is if you're an E4 allele, you have a higher risk of atherosclerosis and a higher risk of Alzheimer's late onset. So that's something they could ask. How it works, not sure, but it might be blood flow. Interesting. All right, now the key pathology for Alzheimer's is proteinopathy. You have abnormal accumulations of amyloid, the beta amyloid, and also hyperphosphorylated tau, which becomes tangled. So these are the two hallmark lesions we're going to look for. Now, first is deposition of these amyloid peptides. It's amyloid made of the beta cleavage of the amyloid precursor protein. This is a critical initiating event in the development of Alzheimer's. Now, normally, we're supposed to cleave it. We're supposed to cleave it in the alpha and gamma position by these secretases. They're supposed to cleave it. But what if it gets cleaved in the beta and gamma position? It's supposed to be cleaved in the alpha. If it's cleaved in the beta position, now you're going to make this abnormally long beta pleated sheet protein. And this can accumulate and lead to the senile amyloid plaques. Now again, alpha cleavage is good. That doesn't cause amyloid. It's the beta cleavage. And again, as we mentioned, the gene for this is R21, so Down's patients are going to get absolutely a lot more beta production. So they're going to get it too. Now the problem with this amyloid is it's going to aggregate and it's going to become toxic to neurons, and then it's going to just get bigger and bigger and basically drown them in protein. It's going to surround them, push on them, and kill them. Now it also elicits inflammation. So inflammatory cells come in, and of course their free radicals can cause injury to neurons too. So your own immune system may be playing a role in this as well because of this junk accumulation. Inflammation comes. Not good. Now I love this picture because it really explains what we just said with a nice picture. It's beautiful. So this molecule here is called the amyloid precursor protein. It's normal. We all have it. We should have it, right? Now, it's supposed to get cleaved in two positions, the alpha position and the gamma position. That's where it should get cleaved. So if it gets cleaved like that, it's not going to make amyloid. Because if you cleave it here and here, the alpha and gamma position, now I've got a small piece, and a small piece. And these are soluble. They'll float away, they'll never accumulate, and they'll never cause problems. So alpha cleavage is what we're supposed to have. Now, unfortunately, we can also get beta cleavage. If you get a lot of beta cleavage, that will lead to disorder. So again, gamma and beta cleavage together. Cleave it here, cleave it here. Now look what you did. I still have a small piece and a small piece. These float away. But this is a big piece. It is not soluble anymore. So this big peptide is now going to deposit. It's going to form a beta pleated sheet. It's going to squish your neurons and become amyloid. It'll be Congo red positive. That is your amyloid senile plaque. Now, why are they bad? Well, they're going to surround the cells and push on the cells. So they're going to squish the cells, damage the neurons. They'll mess up the synapse. And they'll cause inflammation. Inflammatory cells will come in. But notice what else they do. These amyloid plaques activate kinases. Kinases phosphorylate. So now it will start to phosphorylate tau protein. Now, that's not good. Tau is supposed to assemble microtubules. Well, if you hyperphosphorylate it, you get disassembly of microtubules. Again, the neurons are getting injured. So either the plaques are causing injury or the tangles are causing injury. The neurons are going to start dying. And that's where you're going to get dementia here. So again, this tau gets hyperphosphorylated. It becomes aggregated. It tangles up. We call these neurofibrillary tangles. They're made of tau. Tau tangles, tau tangles. All right, now here's your board question. Which one corresponds better with the degree of dementia? The number of senile amyloid plaques or the number of neurofibrillary tangles? Which one corresponds better? Now, I was thinking, well, since amyloid makes the tangles, it's got to be the amyloid, right? Nope, it's the number of tangles. It seems to correspond best with the degree of dementia. Interesting. So they both play a role, and it's the amyloid that starts the process. But it seems like tau plays a bigger role in actually creating the dementia. So I thought that was a nice question on USMLE. All right, now let's talk about some of these lesions, and I'll show you the pictures of them. Here's the neuritic senile plaques. It's made of neuritic processes from dying cells and a core of amyloid. And of course, it's congruent positive. So we take a look at this pink thing here, this pink thing here, this pink thing here. These are the amyloid plaques. Yeah, they'll be congruent positive. Now, this amyloid can not only deposit as plaques, but it can deposit in the vessels. That was called cerebral amyloid angiography. So now the blood vessels will be now congruent, and they'll be very leaky. Increased risk of intracranial hemorrhage, bleeding in the brain. Not good. So two problems with this amyloid: it makes plaques, and it can make blood vessels weak. So remember, congruent positive. Now the second thing is a neurofibrillary tangle. They're in the cytoplasm. They're filaments that are basically tangling up. They're encircling and surrounding the nucleus, and they're made of hyperphosphorylated tau, which is a microtubule-associated protein. Now, notice they're intracellular, but once the cell dies, you'll see them extracellular. They persist. So even though the cell dies, they persist after death. So you'll see shadows of where the neuron used to be. So these things stick around. Now, to see them, we love to give you a silver stain. Silver stain, Bolchowski's silver stain. So Congo red for amyloid, silver stain to see these tangles. Now, do you notice the way this thing over here, this pink thing over here, is the nucleus? Here's the nucleus, right here, nucleus. So this is wrapping around the nucleus, wrapping around, and then coming up here like a flame. Doesn't it look like a flame? It's like a flame, like fire. So some people will call this a flame cell. Flame cell. It's just a neurofibrillary tangle inside the neuron. Looks like a flame. So flame cells. That's one of the ways you can call it. Now, all of these lesions, these plaques and tangles, are most common in the areas where memory is. So hippocampus is common, neocortex, amygdala, but hippocampus is the biggest, most likely area. That's the area you want to look for. That's where memory is made. All right, now another body that's less likely for students to know is a Hirano body. Hirano bodies. Students don't know it. Now they're pink intracellular aggregates of actin protein. That's why they're pink. So here's the neuron, here's the cytoplasm. In the cytoplasm of this neuron, you see this in pink inclusion. It's a big old round thing. Here's another one inside this neuron. These are called Hirano bodies. They're made of actin proteins. Now again, what does the board ask? Things that you know or things that you don't know? Well, every medical student knows senile plaques made amyloid. Every medical student knows neurofibrillary tangles. So they're more likely to ask about amyloid angiopathy, or they'll ask about Hirano bodies, because students just don't know it. Now, here's the rule. If there's a body in the brain, they can ask what's it made of. This is made of actin. So I remember because of Arnold Schwarzenegger, the last actin hero, the last actin Hirano, the last actin Hirano, yeah. So he's got his actin filaments, his strong actin filaments. I got a Hirano body, I'm a hero, I'm actin filaments. It's a totally forgettable movie, says the Alzheimer's Associated. Oh, that's so bad. That's so bad. A totally. You'll see microfilm, a neurofibrillary tangle is made of tau. Tau tangles. Hirano bodies are actin heroes, action heroes. All right, it's almost time to stop. Let me just finish up here quick. So what are you going to see when you look at the brain grossly? You're going to see cortical atrophy. Which part? The hippocampus. So if I ask which is most going to be atrophied, the temporal lobe. So notice these sulci, it's like the Grand Canyon, because look at the gyri, they're so thin. They're so thin. Thin gyri, wide, so like the Grand Canyon. If you're walking along here and you tripped, you would fall and be lost forever. That's huge. Now, in case you forgot what normal looks like, look at the occipital lobe. There's no visual problems here. So this is nice, big, juicy gyri, nice, thin sulci. This is what the brain should look like. Notice how thin and atrophied the temporal lobe, especially the medial temporal. Inside, the medial aspect, that's where the hippocampus is. But is the parietal lobe involved? Sure, that's pretty thin too. How about the frontal lobe? Yeah, that's involved too. So I could ask you what is the most involved and what is the least involved. Most involved is the temporal lobe, the hippocampus particularly. The least involved is the occipital. Okay, so thin gyri, wide sulci, sulci. Now, what happens to the ventricles when there's less brain? Well, they have to enlarge. Less brain means ventricles have to get bigger. So this is called hydrocephalus ex vacuo. And they like to ask that. Notice the size of these are huge ventricles. They're really huge. Look at the size of them. Because the brain is so thin. Nothing, look at this sulci here. It's like Grand Canyons. And the very thin gyri, very thin. So this is severe atrophy in Alzheimer's. You get these big old ventricles, and again, pressure's normal. Normal pressure. Just too much fluid because of less brain tissue. All right, now a famous USMLE question is this. Can the student identify the hippocampus? Can the student figure out? Patient has Alzheimer's, what's most likely involved? Hippocampus. Yeah, but can you find it? Can you find it? Okay, let's take a look at this picture. Up here is our parietal. Here is our temporal. Here is our cerebellum. So I guess these are out. Cerebellum's out. Parietal's out. So now we're down to two answers, and it's this thing right here, this gray thing here. That is the hippocampus. Notice in the temporal lobe, it's kind of the medial aspect of the temporal lobe. Here's the uncus, by the way. This would be the uncus of the temporal lobe right here. Okay, CA1 gyrus will be right about here. That's where the CA1 gyrus is, right about there. Cool. Summer center. That's the most susceptible to hypoxia and rabies. Rabies likes to go there. All right, I think you guys got it. Hippocampus. So make sure you can tell where the hippocampus is. I don't care if they do this plane, this plane, this plane. You better be, when we talk about an anatomic structure, you gotta be able to find it on exam. And that was easy because the USM is gonna look like this. I made it easy. They're gonna show it like this, where all the arrows are really close. And students are, I couldn't even figure it out. They were so close to each other. Well, we're out this dark thing here. That's the nucleus. That's the hippocampus. So you should be able to find it. All right. Last thing are the symptoms, and I didn't put them in here, but we should just talk about the symptoms here real quick. The symptoms of Alzheimer's, I didn't put them in there. It's a slow, insidious. Oh, I actually talked about it already. It's slow, insidious onset of dementia. So you lose memory first, and it's for recent stuff, things you just did, and then later on you start getting confused. You get very angry and get depressed because you know you're forgetting. It's a very depressing disease. You know other people have to take care of you now. And then you get better. Now, is there any drug for it? Well, there is, but they don't work. So there are drugs for it, and the concept is good. They're acetylcholine esterase inhibitors. Let's inhibit acetylcholine esterase. That should increase ACH, right? Anything that increases ACH, that should be good, right? Right? Isn't that the problem here? Yeah, it doesn't work. It doesn't work. No good. So there's a bunch of drugs that are on the market that are supposed to increase your ACH. Doesn't work. So the concept, this theory was sound, but in practice, it doesn't give us much significant clinical improvement. So again, if you can figure a way just to stop the neurons from dying, just slow the progression, you'll be a billionaire. If you can get the cells to grow back and get the memory back, that will be even better. So remember, we're working on stem cells because using embryonic stem cells, it's controversial. Using an embryo, it's controversial. So we're trying to use your own stem cells. In other words, we'll take some of your fibroblasts, de-differentiate them into a stem cell, and then re-differentiate them into a neuron. So I think that's the future, and your generation is going to figure this out. So I'm very excited to see what you guys come up with, because making new neurons, getting new neurons to replace the old ones, then we live forever. We live forever, baby. Fountain of Youth. So good luck, and do it before I get dementia, please. No, I'll never get dementia. I always use my brain. Well, thanks for hanging out with me. We'll come back. We still have two more important things. We have to do neurodegenerative diseases. We have to do tumors. Tumors are through the roof as well. And then we'll be done with the class. We'll be done with the course. So next week, I'm going to be in New York teaching. So probably next week I may do tapes.
I shake too
I'll
much.
try. I'll let you know. But I'm probably gonna do tapes next week because it's hard for me to do it after classes. I'm getting older. I'm the energy I used to lose my voice after several hours. All right, gang. Take care and good luck hunting. Keep up the studying. Boards are coming soon. All right. See ya.